One of the biggest challenges, of course, is reaching patients who are at home, and so we learned to use telemedicine technologies like virtual visits. And as we mentioned in our last conference, we focused had a fairly decent look at some of the other technologies that we can bring to bear to help us manage our patients remotely, such as patient virtual, well, actually, what I was going to say is a patient engagement platforms. But also we learned that some of the technologies that we had used for something like surgical scheduling suddenly became very important when we had massive amounts of cancellations that we had to track and find places for them on the back end when as we come back now. So we had a number of technologies that have shown themselves to be quite successful beyond telehealth. And the other thing we learned is that those organizations that were already poised to deploy these technologies and implemented them could ramp up really fast, where so many others were sort of caught back-footed. Where are these technologies and where are they? So we showed that being prepared, being more technologically advanced, actually was very helpful in this particular situation.
Yeah. The way I've been sharing with other folks is that those who had a mindset and a program and an agenda that was focused on innovation, they reaped the benefit of the innovation dividend. They were much more nimble. So we have a full day ahead of us. Well, it's going to feel like, we're running on pandemic time. So it's a half day, but it's going to feel like a full day. And I'm going to quickly run through what it is that we're going to cover. And then we've got an amazing infectious disease specialist who's waiting in the wings. But so our day, the way this is going to run is we're going to learn what we know about the virus right now, and we're going to have a better understanding of how that has really impacted our workforce. And from there, Stefano, what else do we have next after that? So after we hear about the workforce,
we're going to talk a little bit about the workforce. Yeah, we're going to look at how we're going to ramp up with several voices from different kinds of practices, sharing with us the ramp-up processes. And then we get to hear from Dr. Joe Bosca, the President of the Academy, about best practices as recommended by the Academy, AOS.
Right. And we're going to be talking about the state of telehealth, Zooming, are we really loving it, as in our IT? We're going to be talking about our economy, the healthcare economy specifically, what's there, what's left of it.
Yeah.
And some digital health response.
Yeah, right.
And what are the policies that we need to have around that? And then?
Yeah, we're looking at pragmatic preparatory solutions we can use. And, this is not just pandemics now. We're learning how to practice and be ready for crazy things like floods and earthquakes. This is not going to go away. So what have we learned that we can deploy technologically?
And then we've added something else this time.
We'll get into the symposium.
Yeah, we decided that we wanted, we're all in this virtual world and we're trying to figure out how to connect in a lot better way. So what we're focused on is we've put together a set of symposia where we're going to go to a deeper dive. And we've got some partners that are joining us to help us look at total hip replacement, how we're moving into the outpatient setting with that, remote monitoring at home. And then also we've got to figure out how to use our data and our healthcare records a lot better. So we're going to go into a deep dive with some of our partners. So before we go, thank you for our audience for joining us. We are so excited to have you here. The way to get the most out of this today is using ask questions. That's what we're here, is we're learning together. Ask questions, get to know each other in the chat box on the Crowdcast website. Let us know who you are, where you're from, what problems you're seeing and you're solving. And I think from there, we need to get on to learning a lot more about this virus and hearing about it from a very knowledgeable person who's really looking at this virus at the immunology and the infectious disease level. You ready to go, Stefano?
Awesome.
Okay.
We've done our checklist. We've put on our gloves. We're ready to go. We've got masks on, sort of virtually. And
all right, so it is time for the orthopedic recovery to go.
Great. Welcome to session one of COVID-19, the Orthopaedic Response, powered by Digital Orthopedics Conference in partnership with the American Academy of Orthopedic Surgery, the UCSF Department of Orthopedics, and the OREF, the Orthopedic Research Education Foundation. And welcome, Brian Schwartz. Welcome back.
Good morning. Thank you for having me.
I'm so excited. The session is titled Chasing the Virus, Pandemic-Paced Learning. It's designed to update us on the latest knowledge on what's going on with the virus. So I'm going to turn it over to you. Is that okay?
That sounds great. Thank you.
Awesome.
So there is a lot that going on in COVID-19, and I'm going to spend about 15 minutes hitting what I think are the highlights for you. I'm sure that many of you will walk away with some level of disappointment, hoping that I dived a little bit deeper into one area. But again, I think there's a lot to cover, and I want to give you each of a taste of what I think is most relevant at this time. I'm going to spend just a mere moment talking about some epi. We'll highlight some of the important recent findings in viral pathogenesis. I'll talk a little bit about the clinical manifestations of disease, where we're at diagnostics today, talk about therapeutics and some of the new data out on remdesivir, and then we'll end with an overview of strategies for prevention. So starting off with epi, worldwide, I think probably many of you have looked at these types of slides on a daily basis. It's really staggering to see that we have almost 6 million cases with 350,000 plus deaths worldwide. In the US, we have 1.7 million cases with over 100,000 deaths. And it's just really horrible to see that. The map of the United States highlights kind of hotspot areas where we're having more disease than others. And I want to highlight two important things that we've noted in this epidemic in the United States. One is there are major disparities in the patients who are getting the disease. This was a publication recently from the New England Journal highlighting in Louisiana how Black patients were the ones who were presenting much more commonly with disease. I can tell you from my experience here in San Francisco that our Latinx community is very disproportionately affected compared to others. And I don't want anyone to think that this is a marker of genetic susceptibility. This is really a manifestation of structural racism in our healthcare system. The other thing to note is that our elderly patients are being impacted greatly, and that nursing homes and skilled nursing facilities have taken the brunt of a lot of really severe cases and morbidity and mortality. This is just one publication, but the combination of older age, diabetes, obesity, other cardiovascular, pulmonary risk factors have really made those places hotspots for severe COVID. On to viral pathogenesis. So many of you probably are aware that the virus, kind of like I always think about it as the analogy of HIV causes AIDS, SARS-CoV-2 causes COVID-19, that the virus SARS-CoV-2 binds to the ACE2 receptor. The ACE2 receptor is in the lungs, but also recently it's been recognized that that SARS-CoV-2 binds the ACE2 receptor also in the nose. And there was a publication in the New England Journal of Medicine late last week that really highlighted a new finding that what we found was kids actually have much fewer ACE receptors in their nose than adults, which may explain to some degree why we've seen such fewer cases in kids than we've seen in adults. But really one of the questions in my mind is, how do you go from binding in the nose or in the lungs to this chest x-ray of diffuse pulmonary disease, ARDS, respiratory failure? And what I can say with clarity is that we do not understand this yet, and this is an area of growth. There was a publication that just came out also that looked at and compared patients who died from COVID-19 versus those who died from influenza A. And don't read any of try to read any of the text here in the figure. But what I wanted you to recognize is that when they looked at inflammatory gene expressions in patients who died of COVID-19 versus those that died of influenza A, it was very different. These are different diseases totally. And that the way that COVID-19 stimulates the immune system is not the same as influenza A, and that's why mortality rate is higher. So this is an area for growth. The other thing that they saw in these autopsy specimens was widespread thrombosis and microangiopathy, inflammation of the blood vessels and associated thrombosis, which was unique as well. And I think you've probably seen a lot of reports around clotting in patients with COVID-19, but this was further confirmed, and this is probably an important piece of both of the respiratory failure in these patients in an area of still of a lot of learning. Moving on to thinking about clinical disease. So this is a busy slide, a lot of information here. I want to first start off and look at the pie chart together. So first, I would say when I originally had created a pie chart like this, we would say 75% of patients had mild to moderate disease, 15% of patients had severe disease, and 5% were in the ICU. But I think what is becoming more and more important and people are becoming more and more aware of, and this pie chart by no means is correct per se, because I think we don't understand the burden of asymptomatic disease, and it probably varies by age and population, but there are probably a lot of people that have minimal symptoms or no symptoms or infected, and probably a really important reservoir for transmission. So that is kind of what the spectrum of disease looks like in terms of severity. Now, if you look at the figure here of the person, I wanted to highlight first and start in blue of what are the common symptoms. And again, I think this is something that you're probably all very aware of, that the lungs are affected primarily in these patients, and they present with cough, they develop pneumonia, even early on before they have true respiratory symptoms. We know that on CT scans, we can have ground glass opacities, and unfortunately, many patients go on to develop ARDS and respiratory failure. Constitutional symptoms like fever and myalgia occur, and that some patients go on to develop these cytokine storm syndromes. The other thing that we've identified as being very common are changes in smell and taste in these patients, and something that I think, again, from a pathophysiological standpoint, why this is happening is not fully understood. So I'm highlighting that in blue first. In white are the areas of things that we've also identified as being associated with this disease, but probably a little less commonly. We've had neurologic disease. There's been reports of young people with strokes. Whether that truly is related to COVID-19 or not, or are these just young people with strokes who happen to have COVID-19, I think it is unclear, but people who are critically ill, particularly elderly patients, may present with delirium. We've seen patients present with conjunctivitis, which seems to be clearly associated. There are patients who have cardiovascular issues like myocarditis and develop a cardiomyopathy. GI symptoms, depending on reports, vary, but diarrhea, nausea, and vomiting, and sometimes transaminitis is seen. I mentioned the thrombosis issue, that we've seen high rates of patients who develop clots, DVTs, pulmonary embolisms, etc. The last two areas that I've highlighted here are in gray. And these are areas where I think the findings are likely more of a post-infectious immune-mediated process. But again, we're still learning a lot about this. The skin findings, this is still, I think, has not been clearly, from an epidemiological standpoint, clear association. But there have been these ideas of COVID toes or acral erythema in the toes, and often happens probably after. But again, that correlation is still a little bit unclear. The thing that, lastly, that I've highlighted in the smaller person here in orange is the multi-system inflammatory syndrome in children, where this is a Kawasaki's-like syndrome that happens in children. We're seeing more and more reports of this. It is definitely seems to be immune-mediated and often happens later after infection, in an area we're still learning more about. Diagnostics. Diagnostics are important, and they've been evolving. And there are really three types of diagnostics. And so I'm going to mention each one of those specifically. I think the ones that you all are most familiar with is in the green box, which is PCR. PCR is detection of the viral particles, the RNA itself, and is the main mechanism we use for diagnosis of COVID-19. Most commonly, we use nasopharyngeal swab. I think we still don't know exactly the sensitivity of this test, 75, 80, really kind of depends, and I'll show you on the next slide, of where they are in their clinical course. If you do a nasopharyngeal swab and an oral swab at the same time, put them together, you probably increase sensitivity. Some studies have shown that patients who have severe pulmonary disease, that you have higher levels in the lungs if you did a bronchoscopy. And occasionally you can see shedding in other places. What I would is where we're not finding it is we're not really finding it in the blood, we're not really finding it in the urine. The other way that you could rapidly diagnose is using an antigen test. This is recently FDA approved, just in the last week or two. It's very rapid, where you can get result in 15 minutes. But I think it's important to recognize that you are sacrificing sensitivity with the rapidness of the test. And so what one study showed was that it was 80% sensitive when they compared PCR as the gold standard. So if you say PCR has a sensitivity of 80%, and then you're saying the antigen is 80% sensitive compared to PCR, we know that we're really struggling a little bit. I think the last group of diagnostics that's important to be aware of is serology. And I think we're still trying to understand how to use serology most effectively. Serology is not identifying the virus itself, but it's identifying the body's immune response to the virus by looking at IgM and IgG. How are we using it? So again, on the next slide, I think it'll become a little bit clearer. I think probably the main method for diagnosis is for patients who their PCR levels are coming down and you may have a negative PCR, latent disease, serology may be helpful. Studies so far have not really shown that IgM is really much more helpful than IgG. And there's a lot of variability and sensitivity by test, and there's been some nice publications that looked at that. The other place that serology can be helpful is an epidemiological survey. But you have to remember that if we're looking at a large population where prevalence is quite low overall, that you really need a very, very specific test. And that if you have low prevalence levels and you have an imperfectly specific test, that you're going to have a lot of false positives, and it's going to confuse your epidemiological data. We're also using it when we think about treatment and prevention with convalescent plasma. So taking somebody who's been infected with COVID-19, has recovered, and now they have antibodies that might be able to be helpful for someone else with disease. And so how do you identify those people? You can use serology. And then ultimately, once we get a vaccine that's effective, we'll use serology to identify a vaccine response. So this kind of lays it out all together. And I want you to just take a second and look at the orange line in the middle that says start of symptoms. And the way I've listed that out is day 0. If you then walk to your left and you see exposure at the other orange line, that's when the person is infected first. And so you can see early on, there's a period of infection before you probably are infective, which may be 3, 4, some studies have shown 6 days. What to highlight here is do you see how the start of symptoms is at day 0, but the period of infectivity is actually before then. And that's one of the main challenges that we're dealing with as a community and public health, is how do you identify people who are infective before they have symptoms? And that's why campaigns on screening asymptomatic people is important. So the blue line here is viral load or PCR level, and you can see that you shed often before you have symptoms. And then shedding probably decreases, and the thought is probably around day 8 or 9 or 10 that you become culture negative, and you probably are not be able to transmit it. You're not infective anymore. You can see when serology increases, you can start seeing it increase around day 10. Most studies that show that either 2 to 3 weeks afterwards, that almost everybody, definitely by day 21, will seroconvert. And so this is kind of what the timeline and the way that I think about the changes in the different tests, infectivity in patients with COVID-19. Therapeutics, a lot of exciting stuff going on with therapeutics. So many different studies of so many different treatments are going on around the world. We have antiviral therapies, we have immune stimulators, we have immune inhibitors. We have lots of different approaches that we've been using to try to treat it. Given that we have limited time today, I'm really going to focus on the one that's gotten the most attention, and really the only one that has shown benefit in a randomized control trial, which is remdesivir. And probably many of you had read the randomized control trial that was published in the New England Journal last week. Remdesivir is an inhibits RNA-dependent RNA polymerase. It is only administered intravenously, so it's really given to hospitalized patients. And studies had shown that in vivo models that it probably had benefit. And so there were studies that were put out both by Gilead and the National Institutes of Allergy and Infectious Diseases to look at the efficacy of this treatment. This is the data that was published in the England Journal last week. And this is a preliminary data. They published it actually before they finished collecting all the data. But this study was done in a very robust way. It was a randomized control blinded placebo study. There were over 1,000 hospitalized patients that were enrolled in the study. And really what they found that was when you gave remdesivir, you shortened the time of recovery to 11 days versus those who got the placebo, which was 15 days. And you can see this is in the overall group is in the figure there. And it was statistically significant. There was also a trend to decrease in mortality, which was 7% versus 11.9, although this was not statistically significant. What they found was that the patients who really benefited the most from remdesivir were those who had hypoxia, required oxygen, but had not yet been intubated. But I think we're still waiting for the final data to really better assess whether there could be, are we just underpowered to understand whether or not there is benefit for patients who are intubated and have COVID-19, or is that a group that's really not going to benefit and maybe we should not be using it? I think many of you aware with some of the challenges that are going on nationally with distribution of remdesivir, having limited quantities of this drug, having it be allocated to different hospitals. And there are definitely centers that are having to deal with issues of, I may have multiple patients and I have a limited supply. And from an ethical standpoint, how do I make the best decision about who is going to benefit the most? And these are really challenging issues. And I know each hospital is working on this. And there are groups nationally who are trying to put together some guidelines like the Infectious Diseases Society of America. The last thing I'm going to talk about is prevention. I teach one of the medical student microbiology immunology blocks, and I had used this slide the other day. I hope you don't mind my cartoon drawing. Sometimes it's fun to do this. In the middle of COVID, being able to do drawing sometimes is therapeutic. So when I think about prevention, I think about three approaches. I think about how do we use precautions or personal protective equipment? How do we use things like passive immunity and then active immunity like immunization? In terms of precautions, I want to highlight here that the top patient is not intubated. This is a patient who, let's say, is hospitalized and is shedding primarily through droplets, okay? And I think that's the important thing to remember. So really the way that you're spreading in an average patient is droplets. So these are usually larger water droplets that only are able to make it 3, maybe 6 feet away from you. And then contact, because occasionally these droplets can fall, they can get on a surface. And if you touch that surface, not wash your hands, put your hands on your nose, your mouth, your eyes, you can get infected. So how do you prevent yourself from being infected in these patients is through a surgical mask, not an N95, and a face shield. That will prevent you from being infected from the droplets. And then the contact piece is usually gown and gloves. I want to highlight that this is really effective. This works well. One of my colleagues, I was just looking at his tweet last night, who's been spent a lot of time in Native American reservations down south, where there's been really big outbreaks, who took care of hundreds and hundreds of patients with severe COVID, came back and said, I was PCR negative. I did not seroconvert. PPE works, and I want to highlight that. The other thing to remember is that here in my other picture is the patient is intubated, and that here is when we think about aerosolization. So it's really in patients who are intubated, while mechanical ventilation is probably just mostly the intubation process itself. Once they're ventilated, it's probably much less of a risk. Patients who are using non-invasive ventilations, patients who are using nebulizer treatment, high flow nasal cannula, those are ones where you can see here I have the big droplets, but also the smaller ones. And those stay in the air for longer. And here you can see that now we have face shield, but an N95 mask plus gown and gloves. And these patients will also be placed in a negative pressure room. Okay, so that's PPE and precautions. And if you follow those strict guidelines, you're not going to get infected from your patient. How about passive immunity? So passive immunity is the idea of taking somebody who's been infected and then they've recovered and taking their antibodies and then give it to somebody either right before they're infected. You could use it, consider it as prevention, and that's probably where it'd be most effective, or giving it to somebody who's sick. So this is the idea of using convalescent plasma or convalescent sera. This is available and we use it sometimes in patients, although I'm really curious to see there are randomized control trials going on, and that is going to help us understand whether this is effective or not. This has been used as an approach for many, many years. The other thing that's happening in a research space is the development of monoclonal antibodies, but this is not widely available, but there are a number of recent publications in that on that topic. And then the last thing that I don't have much to say is about immunization. We hope that this works. There's some very early phase 1 data. Some of it's encouraging. We're hopeful this happens in the next year and a half. But there's not a lot to share at this point in time. But I think we all remain very hopeful that this will help lead us out. That is, I believe, my last slide, and I'm going to end here and happy to take questions.
Awesome. I got to tell you, I love those drawings. That was great. Thank you so much. And there's several comments and things. Listen, we are running out of time, but there are 2 questions from the Q&A that I do want to take.
Sure.
One of them, and you can ask them as quickly as you like. One is, any benefits at all from hydrochloroquine and the incidence of cardiac arrhythmias associated with that? This is from Dr. Jeffrey Fried. Yeah.
I'm happy. So the only way to answer this for sure is through well-done randomized controlled trials. And I guess what I can tell you is the good news is those are ongoing right now, and we will know for sure. I would say personally, based on the large series that was published in Lancet just last week, some of the other data, I would say I am not encouraged by its ability to be effective. There's data of people who are patients who have rheumatological diseases who have been taking it for their rheumatological disease who get infected and develop COVID. I think we will only know when the randomized control trials come out. I can tell you that we at our institution are not giving it to anyone outside well-designed randomized control trials that have relevant and important safety precautions in place.
Awesome. 2 more questions. One, I know it's come up a lot in the orthopedic community, has to do with the ability of aerosols to be generated through surgical technique like reamings. And that goes back to, is there any living virus has been cultured from blood or organ tissue that's somehow aerosolized?
Yeah, thanks for asking that. So I would say that, so when they've looked at, there's been several studies that really looked at like PCR from like numerous different body sources. And what I can say is blood is not really, that is not the way this is transmitted. That occasionally there's a tiny, maybe a viral particle that's identified and there'll be a PCR positive. But my general feeling is I would not be concerned about that as being a mode of transmission by any means. And if there ever is any viral particles, it's probably not ability to spread from there. So I would say that is very unlikely.
Awesome. Last one, Mexico City, and this is from Gonzalo Vasquez Vela, hasn't seen the peak of the curve yet, but the government is already opening non-essential business, and we had a partial lockdown. Your thoughts, please.
Well, I would say I'm not a public health official, but I think based in the question that you're asking, I agree. I hear your concern. It definitely, is scary to think about lots of active transmission going on and not having people shelter in place, and that you definitely would make me concerned that there are going to be more and more cases, and balancing good public health precautions with the economic challenges, et cetera, is a really tough decision, and I am very glad that I am not the one who has to make those decisions. Yeah. But as a physician and infectious diseases doctor, I can keep advocating for shelter in place and using these prevention techniques the best we can to prevent new disease.
Brian, I want to thank you again for joining us. I know you have another lecture to give in just a couple of minutes. I'll let you go. Thank you very, very much for participating. As always, you've shed great light. We love your drawings. It was very clear. I love the graphic of the timeline for disease. I think it really clarified why some people who clearly have had the disease test negative. This will come up during the course of the rest of the conversation. It will help us use that information as reference point. So again, thank you so much. And I am going to
thanks for having me.
Have you back. Okay, thank you so much, man. Bye-bye now.
So, welcome to our session on managing a changed workforce. I am so thrilled. I'm Shauna Butler, and I am thrilled to be here with the DOCSF Orthopaedic Recovery. And with me, I've got Iman Abuzaid, who is a physician, an entrepreneur, a risk taker, and somebody who's out there helping us to think about and solve the workforce problems. And in particular, Iman, why don't you say a couple of things? First of all, say hello.
Hi. Hey, everyone.
Yeah. So we have this amazing audience that's joining us from all over the globe. And we just listened to Brian Schwartz give us an update on what we understand about the virus. And he's doing it from an infectious disease, looking the virology, trying to understand a lot more about what we're doing with treatment. You actually have been in the thick of working with the people who are actually taking care of patients and the hospital systems. And we want to talk about this changed workforce that we're hearing a lot about. But before we do that, to really help us understand the change, I think we need to understand where we were with baseline. So why don't you give a little bit of background around Incredible Health, what you guys do, and then we'll go in through some of your presentation to take a look at the underlying challenges that exist within our workforce.
Sure. So I'm the CEO and co-founder of a company called Incredible Health, and it is a career marketplace for healthcare workers. What that means is hospitals and health systems, they use our platform to hire nurses in permanent roles in less than 30 days. It normally takes 90 days or longer.
But you've actually turned this on its head. I was going to say, this is not, so I think from the standpoint of, it's a marketplace, but you flipped it on its head.
Correct. So there's three unique things about our marketplace. The first is that the employers apply to the nurses instead of the other way around. Mm-hmm. The second thing is we've automated a lot of the screening of the nurses. So because we've integrated with so many databases, we can confirm things like licenses and certifications and malpractice records and so on. And then we've also built highly customized matching algorithms. So if you are a recruiter at, say, Cedars-Sinai and you log in, you don't want to see 200 nurses. You want to see 14 that are the right fit for you. And similarly, if you are an experienced, specialized nurse, you don't want to hear from 76 employers. You only want to hear from 4 that are the right fit for you.
Right. Okay.
And so the end result of all this is hiring happening in less than 30 days instead of 90. Salaries on average go up 17% for nurses. Commute times go down by 20% for nurses. So there a lot of benefits and impacts of this.
Yeah. And why don't you, is now a good time for us to start with your presentation?
Sure.
Okay, let's go ahead and bring your slides up.
Yep. All right, so I mentioned hospitals and practices use our technology to hire high quality permanent nurses in less than 30 days. We are based in San Francisco. We are a team of MDs, RNs, software engineers, and we are healthcare and matching technology experts. Just a little bit about me. I am a medical doctor by background. I do not practice at all anymore. But what I've done in the past is I've worked in hospital operations and strategy, and my background is in technical product management. And the reason I started this company is a lot of my friends and family members are doctors and surgeons.
You have quite a few in your family, yes.
We do, yeah. And they are often complaining about understaffing. It is usually a pain point for many clinicians, not having enough staff. And then at the same time, my co-founder, who's a software engineer from MIT, his sisters are nurses. And they're saying, even though I'm experienced, I'm qualified, it still takes me months to get my next job usually. Which is just not at all how it should be. Okay. So the data that I'm going to be going through and the information I'm going to be going through is pulled from our clients. This is just a small selection of them. So we work with academic medical centers such as Stanford and Cedars-Sinai. We work with very big health systems like HCA and Prime and Baylor Scott and White, and we work with a lot of community hospitals too. And we do have a presence nationally. And so this is looking at throughout the U.S.
Yeah, and I was just going to notice Providence St. Joseph's is quite prominent at this moment. They were the first health system in the country to be treating, that we were aware of, that we're treating COVID patients.
Yep, that's right. So I do want to spend a couple of minutes just giving the lay of the land before COVID, right? So what was this market like? What was the workforce like even before the pandemic? So the challenge we were all dealing with is our demand for healthcare as a country keeps going up, right? Our population is getting older. There's just more and more demands on the health system. But at the same time, the number of workers was not increasing to meet that demand. And so healthcare in 2018 became the biggest employment sector in the US. There are very similar trends happening in other countries too. And so today, 1 in 8 Americans works in the healthcare system.
And the other thing on that is the average age of a nurse.
Yeah, that's right.
Yeah, go ahead.
No, go ahead, Shauna. Yeah.
It's in the high 50s, depending upon the specialty. So average is about 54, but in the surgical specialties, it's actually a little bit higher. So we talk about this in terms of numbers, but we also don't really talk about it in terms of a gap around expertise. So
Absolutely.
that seasoned nurse who's been working in your ORs and your EDs, who's got 20 years of clinical acumen, there's a different skill level that is you can't replace. It's not a numbers game.
That's absolutely correct, right? It's even harder to hire specialized.
Right, and to say I bring that up when we talk about those numbers of the shortage, mostly because that group of nurses are set to retire, just like the aging population. That workforce population. So we were already set for a huge set of retirements.
Correct. And then we also can't train nurses fast enough. So in terms of the new nurses, so it's exacerbated on both sides, those that are retiring and those that, we don't have enough training to get more nurses into the workforce as well. So how does this end up impacting the actual numbers, right? And the number of days to hire a nurse for an open position is increasing, and it increases year over year now. And it's the average, our latest data shows that it's 82 days. Now for OR nurses, for specialized experienced nurses, it is consistently over 90 days on average to fill a permanent nurse position in the US. The other thing that's happening is that labor as a percentage of revenue is going up. As the labor market becomes tighter and tighter and the shortage becomes more acute, the cost of hiring a nurse continues to go up. Their salaries are going up. And so therefore, as a percent of your total revenue, labor is taking a bigger chunk of it. And then the other thing that's happening is turnovers increasing. Now, the latest data we have is for nurses is that it's the 19% is the annual turnover for nurses in the US. That is exacerbated by the shortage, because when you are understaffed, you are more likely to quit.
Yeah, it's hard to work in those environments. It just, so once you have a reduced or a higher workload, then it increases the amount of people who are leaving those roles, which just is a nasty cycle to be in.
That's right. And so just a quick comment on the cost, right? The cost of the shortage. when a hospital, for example, is understaffed, they are spending on overtime and on travel nurses. Those two things, contract workers and overtime, is usually 1.5 to 2 times more expensive than your permanent nurse. So that means executives are under a lot of pressure to reduce overtime and contract labor and increase their permanent staff because it is impacting their bottom line. Okay. Burnout increases of existing staff and turnover increases. When a nurse is working more than their average 8 to 12 hour shift, they are 2.5 times more likely to quit, right? The other thing that happens is the suicide rate for nurses, unfortunately, is 45% higher than the average American.
Yeah, I was saying when we talk about they're likely to quit, most of the reasons that they quit is because of this moral injury. They see that they are not able to deliver the care that they'd like to. We see that errors go up, that patients are harmed. So there's direct impact between the stress level and the staffing levels and the quality of care and the overall health and well-being of every single member of those of that care team.
Absolutely. So as you pointed out, Shauna, a big impact is the quality of care, right? So some of the data we have is when a nurse is working more overtime beyond the 12-hour shift, he or she is more, it increases their medication errors by 20%, right? It's simply just because of fatigue, right? Patient mortality at hospitals that are understaffed goes up by 4% when they are understaffed. And of course, so ultimately the fatigue, the quality of care impact trickles down to patients. And so patient satisfaction, of course, goes down. Physician satisfaction goes down. Nurse satisfaction, of course, goes down. And this is all further exacerbated by the intense competition for talent, for nurse talent.
Yeah. Okay.
So I did want to spend more time talking about COVID-19. So now, okay, fast forward. We got the lay of the land. The pandemic hits. What is the impact on the workforce, right?
Yeah. So in that, from the standpoint of, let's be really clear. I want to I think it's important to level set and to just make a very important statement. All of that information that you provided just now, all of those stats where we were talking about shortages and stress levels, that was before the pandemic. That was before. All right.
Exactly.
And so now we've heard these stories. We've seen images. We're developing an understanding as best we can because many of us are not inside. And the other part that has been so unusual and interesting is because there have been no visitors allowed in hospitals. Again, the exposure that the public has to how difficult this care environment is, and actually all of our non-essential staff. So many of the administrative staff, they are not there as well. So it's, we're going to put some numbers and some words around all of this to help people understand what the impact of COVID has had on our workforce and why they're changed. So do you want to go through the numbers first? We have a video that we wanted to share to try to give some images of that. Do you think we should do the numbers first or do the video first?
Let's do the nurses. Let's do the numbers, and then we'll switch to the video because the video gives a lot of color. So we had done a very detailed study on nurses and how COVID-19 is impacting them. We conducted this study in April. When we published it, it was covered by Bloomberg, Becker's Hospital Review, Yahoo News, and it made news because the mainstream media and honestly mainstream audiences don't fully understand the impact that COVID-19 has on healthcare workers. And so specifically some of our findings, just a couple of examples. So 2/3 of nurses said their facility does not have the appropriate PPE to properly protect themselves. Another thing, 59% of nurses said they do not feel adequately supported by their facility to deal with the added stress of COVID-19. And only 2% of respondents said their facility was very prepared to deal with COVID-19. So I'll pause there so Shauna can show the video to give some more color on the stories behind these numbers.
Yeah, and before we go to that, some added numbers that I think are really important is a study that was done in Wuhan. So it was published in JAMA Open Network. They talked with 1,300 frontline care provider. Well, they talked with 1,300 people who were working at 34 different hospitals. And what they came out of that is that a significant number of people, upwards of 50%, even on some of the dimensions of mental health and mental well-being, 72% were describing how they were having signs of depression, anxiety, difficulty sleeping. So this huge number, and they actually called out in this study how it was affecting nurses, and they specifically said women. So it's an interesting study that is in the JAMA Open Network. So can we go ahead and roll with the video, please?
Especially, now that we all watch movies about superheroes, like, heroes aren't really people, but we're meeting it as people who are fallible and imperfect and tired and cranky and
terrified,
frustrated,
tired,
and overwhelmed.
As I'm getting ready for work, I'm scared.
It's terrifying.
Scared, I'm anxious, but I'm also thankful and I'm very hopeful.
I have been a respiratory therapist for 9 years, primarily working in adult critical care.
I've been an ER nurse for 19 years.
I have been a NICU nurse for 19 years.
I've been a nurse for 20 years.
I've been a nurse for over 30 years.
I'm a doctor.
I work in the post-acute care world.
I'm a registered nurse.
We are healers.
As a healthcare provider, this is something we've always trained for. You don't expect it to ever become a reality.
The biggest source of fear is the unknown.
I think it's the unknown.
The TV, the media, the fear.
I am scared of what's to come.
Do I have enough to give?
We are asked to fight with little to no protection. And then when we offer to bring our own, it's not allowed.
It's like walking on eggshells the whole time, wondering, am I wearing enough to protect myself? Am I going to be able to take care of this patient?
As a single mom, no, make that a solo mom with no one else to raise my kids. I worry every day I step into the hospital to work.
Can I safely go home to my family and not worry about harming them?
What if something happens? Who will take care of my kids?
We signed up to do this, but we signed up to do it safely.
Like I mentioned, medicine makes me be the best version of myself I can be, but it's hard to keep that up. And it's have this ideal that you want to live up to because everyone's telling you to and cheering you to, but you just kind of, at a certain point, you just can't.
But at the end of the day, you leave work and there's notes all over the chalk sidewalk. People are so thankful that you're there to help them. So I feel joy, pride in the choice that I made to be a healthcare provider.
Really, all I want to do is be there for my team and do what I can do and to help them and to protect them and to be there for each other.
Because this is what I signed up for, to care for others.
Just watching.
Sometimes I have to catch my breath. So these numbers that we've talked about, we have to honor the humanity of our workforce. I saw a presentation that Sachin Jain gave yesterday as part of Health Evolution and talking with many of the healthcare executives. And that was, I thought, a really good way to think about this, that we do have a changed workforce and it is beyond the numbers. The CDC just recently released data that they have that indicates that there are more than 62,000 reported cases of our healthcare colleagues who have become infected or ill and hospitalized. And tragically, we're of the reports, there are at least 300 of our healthcare workers who have died. So I think it's really important as we are recovering and we are moving back into practice, moving towards a full level of service, that we need to be mindful of what this experience has been. And before all of the pandemic, we already knew the amount of stress that our healthcare workforce has been under. We need to give some concrete, say, what do we need to be doing? Iman, you have been spending a lot of time coming up with very concrete solutions to address a range of needs that cover the emotional, the financial, the physical, and the spiritual.
Yep, that's correct. So I'll go into some of the solutions that many of our clients are implementing. Before I do that, all of us have read in the news about the layoffs, the furloughs, the cutting of hours, particularly the nurses that are not in the ICU or the ED. And so on top of all of the workplace stress, there has been financial pressures for healthcare workers as well. And we know doctors have been impacted as well. And so what we saw on our platform is the hiring of ED and ICU nurses went up dramatically, 50% or twice as much, compared to roles in other areas. Like for the first time ever, OR nurse hiring slowed down, right? Because elective surgeries had paused and there wasn't as much of a need for those staff. And then the other thing that we saw is the speed of hiring accelerated for these ER and ICU teams because of the urgency to hire. And so all of a sudden, hospitals were open to doing interviews virtually instead of on site or in person. And they were doing whatever they could to get the staff. And so by late May, we are starting to see, as hospitals are opening up, we are now starting to see a rebound in hiring for the OR, the PACU, like the other areas beyond the ICU and the ED. So some of the solutions that our clients are implementing to support staff, and this information is all just as of May 2020. Look, this pandemic was a shock to our health system. We were not adequately
a health system that was already under stress.
Exactly.
It's not like, it's like, let's just not get overwhelmed at this point.
Exactly. And so many hospital leaders spent, March, April, preparing and getting all of this stuff in place as quickly as possible. So first and foremost is getting adequate PPE. There are still reports of many hospitals that are still struggling with this, but that is a key area of focus. The second is implementing their infection control protocols. Unfortunately, the CDC was very slow with providing these protocols. And so many hospital leaders had to come up with their own, right? And so that everything from the testing of patients and healthcare workers for COVID, separating out COVID versus non-COVID patients into having COVID-specific units versus non-COVID units, thinking a lot more thoughtfully about scheduling in the OR, where low risk or non-COVID patients are in the morning, and those with COVID and higher risk are in the afternoon. Of course, more increased cleaning of the units. A third thing is increase in mental health counseling. We mentioned earlier about the impact of the stress from COVID, the long hours, just the fear of being infected as well. So let's
talk about that from the standpoint of in a lot of these surveys where we've been talking to all the healthcare disciplines, anybody who's in there, the things that they identify, the things that that are causing them the greatest amount of stress. The first thing is they are all afraid of getting sick. They're afraid of contracting the virus. And so that's where all of the PPE and the way we organize our teams and how we're planning our surgeries and any of the care that we give, that's been huge. Second thing that they're worried about is then I don't want to get my family sick. So that really increases the fear that they have for their families. They're also talking about just the high levels of uncertainty of treating something that is brand new. We're used to knowing how to do things, and this is completely brand new. We're figuring out the therapeutics. They've also talked about their fears of the financial impact as we have, had this delay in surgeries or reduce the scheduling. They're concerned about the financial impacts, and they're reasonably so. We've seen huge numbers of layoffs. People have been asked to take reductions in pay. And then the other part is they've talked about their emotional fears, the sense of, did I do enough? Did I do the right thing? Concerns about their colleagues, and just the emotion of the vigilance required to keep entire teams safe and keep other patients safe, and wondering if they've done enough. Yeah. So continue on. I mean, from the standpoint of getting the PPE addresses some of those fears, but the emotional well-being, these are structural issues that need to be addressed. So how is it that you're recommending, I mean, when you're talking with the leaders, what are we doing to put in resilience program, have wellness offerings, remove the stigma? That's a big part. Anonymize, the screenings.
Yeah, I mean, it's everything you said is correct. I mean, honestly, they're like, as of early May, they're still scrambling to put all this together, right? Like this is a huge rush to put these programs in place, particularly around mental health. Yeah. They definitely were focusing on physical safety first, and then are now turning their attention to the mental safety. The other thing is the childcare, right? So,
well, this has been the other fear that they've talked about is, as we quickly get things back up to speed, talk about that. What do they? I mean, that's what they've said is I don't have any childcare, and I'm afraid of getting my family infected, and I don't have a place to stay. Our families are separated. There are some very serious challenges just within the logistics. I mean, I've even heard some say it would be very helpful if they had people to do their laundry. Right.
So what we've seen some hospitals do is expand their childcare benefits. So they will cover the cost of childcare, because a lot of these younger children are home from school, right?
Hopefully being homeschooled, right?
maybe not. And then the leaders also expanded sick leave, right? So if you did contract COVID-19, that triggered a whole nother set of benefits related to sick leave. That's different and on top and more expanded than your just average sick leave. And then on hiring, they're really trying to reduce the number of people that need to additional people that need to come on site. So they've really embraced the automated scheduling, the virtual interviews on hiring. And then of course we've heard a ton about the embracing of telemedicine too.
Yeah. So what else have we got that we need to, let's talk about from the standpoint of one of the other things that is fundamental right now to being mindful of this changed workforce is culture building. So there are a lot of these logistics. Yep, I've got, we're going to get you all the PPE. Let's make sure you've got childcare. Let's make sure that you've got sick leave. Let's make sure that you have transportation. For a lot of folks, they are concerned about having to be on public transportation. So we're addressing all of those things. We also need to be looking at infrastructure. How are we using technology better to remove what was already a huge amount of burden before all of this came, before the pandemic? So we've got the ability to think about how do we relieve some of the stress around the regulations and the compliance that were there, over-regulation, everything to do with things that were mind-numbing tasks. So I think we have the opportunity there. The part that I think we need to really think about is the culture that we're building. How are we building a culture that, if we're caring and healers and healing institutions, what does it look like to build a culture of caring for the caregivers?
Absolutely.
You got some other data on that you wanted to share?
I do have some, yeah. So hopefully there will be later sessions about telemedicine and virtual care.
Yes, we will.
Okay, but our expertise is actually on staffing, which is often a top priority for those running practices and those running hospitals. Mm-hmm. And so I want to share a little bit of information on that, right? So we mentioned earlier that the way our platform works is the employers are applying to the nurses instead of the other way around. We've built proprietary screening algorithms. We've built custom matching algorithms. That's layered in with a bunch of data analytics that enables teams to improve their hiring process. Because rapidly hiring and hiring the right people directly impacts your finances, as we said earlier, and your quality of care.
You know, the other point that I think is that I've heard you talk about this, and I hadn't thought about it until I heard you say it, is when somebody gets hired rapidly, when they have a really good experience, it builds trust within your institution, excitement, like, wow, they are completely on top of this, as opposed to having this frustrating, why did it take so long? So can you just say a couple of things about the value that it creates as far as building culture when you're able to rapidly hire?
Yep. So HR teams call that the candidate experience, right?
Okay,
so
right. Thank you for the language.
when there is a fantastic candidate experience, which majority of that is driven by speed, to be honest with you, because the usual experience of healthcare workers is
painful.
I applied to 15 places. I never heard back. It's a black hole. You know, those are the very common complaints, even from those that are very experienced and specialized, right? And so teams that focus on this candidate experience component and the speed component have noticed that the employee ends up becoming more engaged, right? After they become an employee, they are more likely to refer their own family members to the facility because they have a very positive impression of the facility.
Just
from
how
the
they
front
were
door.
treated. Yeah.
Exactly. So it's almost like hiring is like, it's like the front door and the very first experience your healthcare worker has with the company or with the employer. And so making sure that is a fantastic experience has many knock-on benefits as well. Okay. So really what ends up happening when they are using our platform is, and we talked about the role of automation, instead of manually sifting through these third-party job boards like Indeed, LinkedIn, Monster, or the hospital's job board, you are looking at a much smaller set of candidates that have been custom matched to you and already pre-screened. And this ends up saving a considerable amount of time for HR teams and hiring managers, so they can honestly just basically do less work and get better results, right?
Yeah, yeah.
And so I wanted to do a quick poll exercise with everyone.
Yeah, and we're pretty close to, from the standpoint of, we are pretty close to wrapping up the session.
Yep.
So why don't we do a quick poll and outline what this hiring experience, candidate experience, what the typical one looks like.
Yep. So what I have here is like across the top there, it's the standard hiring process, right? Mm-hmm. You know, you find the candidates get interviewed, the candidates gets interviewed by a hiring manager, job offers are sent, job offers are accepted. And so I have 3 competitors. This is actually happens to be data from our LA market, from the LA market. Competitor A happens to have the highest salaries in their market. Competitor B has the biggest brand, right? It's a global brand. Competitor 3 has the fastest speed in hiring. They are able to hire in dramatically fewer days than their competitors. And so you can see the number of days and the amount of time that candidates are spending in each step of the process. So the poll for everyone is by looking at this data, which of these 3 competitors, A, B, and C, hires the most candidates and also the most experienced and specialized candidates?
Okay, so A was
highest salaries.
Highest salaries. B,
biggest brand.
Biggest brand. C is fastest hire.
Fastest speed to hire. Yeah.
Okay. All right, so the votes are coming in. It's fun watching how this happens in real time. And why are we not doing online voting for everything? Yeah. I hope that, I was going to say, I feel safe in these results. I don't feel like we've been hacked. So good to know. Okay, so we have a clear winner. I was going to say it's going to keep going. I invite people to keep voting. But the survey says C. And
C.
the answers?
Is C. Yeah.
Okay.
When we started this company, we were like, oh, it's so obvious. The people who pay the most and have the biggest brand are going to hire the most. And our data definitively shows that those that hire the fastest, even if they don't have a great brand, a big brand, and even if they're not paying the most, actually hire the most. Okay. And so yes, there is a need for speed when you're hiring. So I'll just wrap up. 68% of candidates are accept the very first offer they receive. So speed is a huge competitive advantage. And I just end with just a quote from the chief HR officer at Stanford, who, really this is about our missions. Our missions as facilities and healthcare workers all has to do with delivering quality care. And with the ongoing shortage, it's taking his team longer and longer to find these ideal, specialized, experienced candidates. And with Incredible Health, we're consistently hiring under 3 weeks. So even with a massive brand like that, they still are using technology and embracing it to hire faster. And so I just want to end with my contact info if anyone wants to get in touch.
Oh, I was saying, I just took it off. I'm so sorry.
That's okay.
So anyway, I'm just really grateful from the standpoint of all of the things that you guys are doing. Really, it's on behalf of my colleagues, it feels very personal.
This is generally a group of workers that's underappreciated and overworked. So
and that means a lot coming, it's nice to hear somebody else know that data and to be able to vocalize that. And I am in touch every day with so many people who are in the midst of taking care of patients. And I tell you, their stories, it's hard to hear the amount of suffering that they are seeing and having to take on for the families who cannot be with them, and then for their colleagues. And so I am so excited for us to get back into delivering care, because there's so much need. There was so much need before this pandemic, and I worry about those people who have not been able to get the care. And I know that we've got skilled, dedicated, super smart professionals who are just eager to get back in there and take care of our orthopedic patients.
Yep.
I think we just need to do it recognizing the humanity of our workforce.
Absolutely.
So
we need to do whatever we can to support these workers.
Yes. Yeah. And know that it comes from, we need to think about systems of caring. So again, with that, I will leave it and say thank you. And we will see you online. Keep doing all those good things and taking good care of our workforce.
All right. Great. Thank you so much, Shauna. I appreciate it.
Bye, Aman.
Bye.
Okay, welcome. We're in session 3 of COVID-19, the Orthopaedic Recovery, powered by Vigil Orthopedics Conference San Francisco, in partnership with the American Academy of Orthopedic Surgery and the University of California, San Francisco, Department of Orthopedics. We're also joined by the American Telemedicine Association and the OREF, the Orthopedic Research Education Foundation. So we're very excited by these partnerships. This session is titled Ramping Up, and if only we're like flipping a switch, as many people have already noticed, it's much easier to stop the machine than to get it going again. A lot of questions come up as how to go about doing this, and so we're joined today by Dr. Bruce Cohen, the CEO at Ortho Carolina, a large and very well-known independent academic orthopedic specialty group with over 400 providers serving North and South Carolina. Dr. Cohen is also the president-elect of the American Orthopedic Foot and Ankle Society. So we're excited to have you. Thank you for joining us. Andy Miller, right next to him, he is the CEO of a smaller practice. We thought we'd bring in different perspectives. He has a 15-person practice in Santa Clara, Ortho North Cal. So thank you for joining us, Andy. And right now I'm going to bring in our last guest, Dr. Tom Barber. And many of you know Tom as well. Tom currently is serving as Associate Deputy Physician-in-Chief of Preoperative Services at Memorial Sloan Kettering Cancer Center, but has a very long and storied history in the world of orthopedics and has a lot of insights, many of which we're excited to share because he was in New York during the entire COVID crisis and as it peaked, and has a lot of learnings from that. Gentlemen, thank you for joining us.
Good to be here.
Awesome. All right, so the format today is that I'm going to just lay out some questions, some thoughts, some problems that everybody seems to be handling, and hear how each of you is managing them and how you're thinking about it. We may or may not hear from each and every one of every question just so we get through it, and then we'll take questions from the audience. So for those of you in the audience, feel free to start adding questions in the Ask a Question section at the bottom of the screen. The idea there is looking at practice issues, things that you're worried about in terms of starting back up again. So let's start a little bit with testing. Now, earlier this morning, we heard from Brian about the science around testing. Bruce, what are you doing around testing for patients now who are coming in for surgery?
So at all of our facilities, both inpatient and outpatient, we are requiring testing. Testing is done within 3 days prior to the procedure. For our outpatient facilities, we're asking the patients to self-quarantine as well. So we're doing testing basically for all patients. We're requesting the self-quarantine for 5 days or so before the procedure. Obviously, compliance to that is going to be a little bit questionable, but patients are self-reporting that.
Tom and Andy, any difference from that?
Yeah, I think for us, we're doing testing 48 hours in advance. And we found in New York right now about a 4.5% rate of patients who are asymptomatic coming in that are positive for COVID. And I think the second piece that we're dealing with extensively right now is the testing for previously positive patients. So patients that come in that 4 weeks ago had COVID, how do you test those folks? Because a lot of them are ending up being positive for 6 to 8 weeks because of viral RNA fragments and not because of infectious nature. And so what we're doing there is after 4 weeks, we're considering them free of COVID transmissibility. And so we're not testing 4 weeks after the initial positive test. And then we're allowing patients that were COVID positive and asymptomatic for more than 10 days to have a negative test 48 hours in advance and still have surgery. So they have to wait 10 days after symptoms and or 10 days after a positive test, have another negative test before surgery, and they could go ahead. So that's our testing routine primarily.
Yeah, it's a very interesting problem that you brought up, this idea of the previous testing patients. So, and Andy, we talked earlier, you're seeing some testing of the staff and of these physicians as well at your hospitals?
Inpatient facilities is requiring testing of the of our surgeons and our assists, our PAs. Correct.
Tom and Bruce, any trace of that in your systems?
We are offering testing for all physicians and all staff. We are not requiring it, except for those staff who are working on COVID units. So those people that are on COVID units are required to take routine testing, because we had one episode of nosocomial transmission by a staff member. And so that was one staff member infected about eight patients and other staff. It was not all patients. It was 4 patients and 4 other staff members. So that was a big problem. And then the other thing we're doing is requiring filling out a survey every day before you go to work on symptomatology. And you have to show the app at the door to get in the door, which shows that you're green, meaning that all your questions were answered in a satisfactory manner.
So these are chatbots, right?
It's not a chatbot. It's just it's a website that was built specifically for us, with 5 questions that are asked of the employees. Do you have a fever? Do you have a cough? Those.
Yeah.
And do you have a nose bleeding? Any of those kind of questions. And so, if they answer yes, then they're not allowed to come to work. So they get a screen that basically says no, you're not allowed to go in, and they have to go see their physician.
We have we use a chatbot technology. It's a little bit snappier, but I'll say, Malcolm, either of you guys have screening tools that are technology based?
We do not technology based. We're doing manual screening, asking the questions, temperature checks. We are not testing for surgery or even for the office. We're not testing our staff or providers.
Got it.
We just don't have access to that.
Yeah, we're not testing our office staff either. We just have left that as it is for now, but if we need to escalate, we're prepared to do so.
So I think the big change for us, Steph, is we're moving to saliva-based testing as opposed to, doing the big brain biopsy, type of thing.
Just the swab that goes in the back of your head.
The swab that goes way up there.
So unpleasant. So I will switch a little bit real quick. Let me switch a little bit to the clinic. We've put these restrictions into accessing the hospitals, but we're now seeing patients, or our clinics are opening up again. Let's talk a little bit about how you manage a patient coming into clinic. First of all, are you letting patients come into the clinic with family members into the office in the back room? Let's start with Andy.
Yes, we are, but we have full screening at questions at the front desk. We have screens at the front, plexiglass screens. In Santa Cruz, in our Santa Cruz office, we are requiring face masks because that's a county regulation, and we do try to minimize family members going into the treatment rooms with the patients. We encourage them to go out and wait in the cars, and we text them if when we need to contact them.
Bruce and Tom, anything different? So Bruce, go first.
So at all of our offices, we have screening. We screen them on the phone. Then we have in-person screening for every patient. They have to, answer the questions. They get a temperature check. Visitors, we have a strict visitor policy. We are restricting visitors unless it's an incapacitated adult or a minor. The remainder of the visitors have to wait outside or in the parking lot. Some will, FaceTime or something during the visit. But we're sticking to a pretty strict visitor policy currently.
I love the FaceTime idea. I've done that several times. Works great. Tom?
Yeah, we're restricting visitors as well. We have no visitors yet. We're just going to start a new New York pilot to have one visitor, but they will also be screened with questions and temperature as well.
Yeah, makes sense. Let's talk about prioritization and scheduling patients. When we started, the Academy put out a 1, 2, 3, 4 concept where we had the super urgent, people couldn't wait regardless. This is trauma, infections, and cancer. And then you go all the way to 4 being fully elective. So starting with Bruce in Ortho Carolina, what are you doing in terms of who are you allowing to come to the hospital for surgery at this point? What kind of orthopedic patients?
Yeah, so now we're pretty much open to full elective at our outpatient facilities. The inpatient facilities are obviously based on the hospital's policies, but with respect to all electives, with the exception of some of the patients with increased comorbidities who are looking at a much longer than a 2-day stay in a possible SNF stay. Those are being screened individually and on a case-by-case basis. So one of our hospital systems is allowing all the tiers, and the other is carefully considering the sicker patients and the ones that may either have an extended inpatient stay or look to need a SNF or a rehab stay. We're trying to be very careful with those. And most of those are, as you would know, total joints and probably complex spine.
Right. We at UCSF have actually almost gone the other direction. We kind of, the complex arthroplasty that really failed implants that weren't infected, wasn't cancer. We're trying to take care of those folks because they seem to be most need. But we definitely seem to be opened up pretty normal. Pretty much as long as somebody wants surgery, we can accept them. Tom, anything different in New York that you're hearing?
No, the only difference for us is we're a cancer hospital, and so everything is cancer. We had to really stop doing a lot of surgery for a period of time on these urgent patients, which was very unfortunate. But now what's interesting as we're coming back is our demand is down by about 40%. Because people don't want to come into the city. And so our regional sites, actually in Westchester, New Jersey, are doing well, but people don't want to come into New York City right now. And so we're having challenges rebuilding the demand. And so we have plenty of capacity. We're wide open for business, and we will see people in a very safe manner, but we're not seeing the demand that we did before.
So let's definitely come back to the question of demand and safety of the hospitals. But let me get to Andy, because you're the private practice guy. What's going on in your practices with respect to that question of priority? If you're aware, if you know what you guys are, if you have a threshold for acuity.
Yeah, with our ASCs, it's pretty much wide open. Totally elective. We're doing all its procedures. With the hospitals, it kind of like. With Bruce, it varies. Some of them are still phasing in with the scaling system. As far as touching on Bruce's topic with the demand, we still are seeing quite a few patients that are hesitant to come in and have their procedures performed. But our surgical volume is back to probably about 80-90%, which is pretty good. We figured at this point. And we feel like in June, we'll get closer to, 100%.
Yeah. So let's talk about volume. So Tom, you already mentioned that surprisingly, you think oncology would not be impacted, right? These are emergencies. But you're seeing a drop. Maybe people are staying out in New York. Maybe they're getting their care elsewhere, I suppose.
It's a combination of things, Steph. One is wanting to stay out of New York, and so we don't see the international people coming over, for instance. The second piece is that the screening procedures that are being done in offices, whether it's in a standard orthopedic office or in a primary care office, they're not getting seen in a timely fashion. So unfortunately, patients are coming at a later stage in disease to us as opposed to early. But we're also seeing a higher conversion rate. So the patients that are coming really need a surgical intervention, if you will, as opposed to those that happened before. So,
right. Bruce, demand, what are you guys seeing?
So right now, both office and surgical volumes are around 90% are normal. And, some of that's exhausting the backlog of people who got postponed or delayed. But there's still a subset of patients who, the message is, why don't we wait till after the summer? Why don't we wait till July, see what's going to happen? I think the more difficult question is, what's everybody predicting for Q3 and Q4 when 40 million people still out of work? Can people afford their out-of-pocket expense? Did people lose their benefits? And so we're trying to, in our projections, probably predict a 10 to 15% decreased volume in Q3 and Q4 because not because of healthcare, but because of the economy. I may be wrong there, but I just don't know.
That's a really important question. In fact, we have a whole 45-minute segment dedicated to the economy with Kevin Bozick and one of our professors from UC Berkeley, who is very well versed in this. So really good question. You also sort of brought up the question of the patient perspective. I mean, we've been hearing that some of the drivers of people not coming to the hospital are, like you said, potentially loss of job, loss of income, loss of insurance. fear of coming to the hospital. So I want to tackle those questions a little bit. Tom, you track you guys' data, you're in the thick of things. What's the chance of getting infected as a patient who is not infected coming to a hospital where they may have been treating COVID patients? Do you have a sense this is a very rare event? Should patients be concerned? Is there a reason to stratify patients into non-COVID hospitals, which is actually kind of my next question. But yeah, what's the risk of coming in?
I would say it's extremely low. The risk is actually higher for the employees and particularly anesthesiologists and CRNAs than it is for others. Because early on, we had 35% of our CRNAs out due to COVID. And so that really happens because of their workplace. I think that the patients themselves, we have had some nosocomial spread. As I mentioned before, it is very rare. And since we've been very rigid as far as our employee PPE and our screening for employees, we've not had that issue. So I think we've learned to do it well. And once you do it really well and you know, and you cohort the COVID patients on particular wards and with particular staff who know how to disrobe, for instance, they have good ventilation, et cetera, in their areas, we don't have a problem. But I think it was that learning process and learning how to do it well. And now I think it's very, very safe for patients in all locations. And as long as everybody wears masks, I think we're fine.
And Bruce, are you seeing, have you had an experience at any of the hospitals, but also you were telling me earlier that you interface with approximately 99 other healthcare systems in the space as part of one of the groups you belong to. So what has been that experience?
So our experience has been the two large hospital systems have tried to have facilities that don't care for COVID. So obviously our experience in North Carolina is much different than the experience in New York. So we have the luxury of being able to get COVID patients out of certain facilities or restrict them from certain facilities that can become elective surgical facilities. I mean, you can't use the word COVID free unless you test everybody every day because you don't know who's there and who's asymptomatic. But I think trying to get patients who, under investigation, get them tested, and then if there's any concern, you either get them out of that facility to another facility where they still can be cared for. But then it gives the patients the comfort for elective procedures that they're in, that they're at less risk. We all know that the asymptomatic carrier is the one who's going to get them infected, probably not the known COVID patient because we take precautions. Most of the other independent groups, I'm part of a group called the Ortho Forum, which represents 99 of the large groups in the country. And so we've been having weekly calls for the last 8, 9, 10 weeks and exchanging information. And we learned a lot from our folks in Seattle with the large group Pro Alliance there. And we're all sharing information. Everybody's around at the same point, with the exception of maybe New York and Detroit and Boston and some of the urban areas that really became hotspots. Everybody else is pretty much approaching it in a similar manner. The ASC volumes are up because to the patient, the outpatient environment seems to be a safer place to them conceptually.
Yeah. So, but we just covered the fact that you're right. It seems to be, but it probably isn't. So probably we don't have any reason to think that in the context of our well-screened hospitals with staff and PPE, there really doesn't sound like there's a major risk to the patient coming in, and we're seeing that at UC as well. So second question around that is a patient's coming into the hospital, taking care of it. I'm thinking about costs. Is this people may have lost their job, income may be limited? Do we have a way to support or help patients make sure that they understand what their costs are coming out of these operations? Because if finances are problematic going into a recession, is this a responsibility we have, or can we work with our anesthesia insurance partners to have more clarity around the billing? Bruce, want to take that one? Yeah, take that one.
I think we're going to have to change our mindset from a healthcare standpoint. I mean, most places will demand, the patient responsibility up front, well, people aren't paying car payments, they're not paying house payments, they're deferring rent. I think healthcare needs to start thinking in similar manners, allow people to finance these expenses over a longer period of time. Well, we're exploring those ideas through some credit options with longer payback periods, because we're going to have to, because I truly am worried that people aren't going to be able to afford the out-of-pocket expense, and they're going to delay care. And maybe in cases of cancer and cardiac and things like that, people's health is going to suffer. And so I think we need to be innovative and adopt some of the same policies that the auto industry has done, and the real estate and landlords are doing. Because I think the perception in the United States is going to be, I can defer my payment on everything until the economy gets better.
Tell me thoughts about that.
I would agree 100%. I don't think we as an institution are at the point yet where we can offer those kinds of alternatives. But I think that's the direction we all need to go in one form or another.
Andy, you're CEO of a small group. The finances are not quite as flexible. What are your thoughts?
I agree that those are key factors. And with our practice, we're trying to be more creative, come up with payment plans, help people out, because we know the hardship that everybody's going through at this point. Our employees are going through the same thing, and we're sensitive to that. So we're trying to be flexible and work with patients.
Right. I think the message of us needing to understand the position that patients are in coming up with flexible plans resonates very well. Thank you for sharing that. Another question that's more patient-centric is discharge. Many of our patients in San Francisco with steep hills, walk-ups, a lot of people living alone, many of them would go to skilled nursing facilities for recovery after surgery. They just don't have the social infrastructure to be taken care of at home. Are skilled nursing facilities a safe place to discharge patients, which are not the same as nursing homes? And let's be clear about that. Bruce, why don't you start?
Well, I will say before COVID, with a lot of the push that we've been doing into value-based care, we've been really trying to decrease our use of SNFs. And I think we saw that with some of the programs and bundles and BPCI and BPCI Advanced. So it was already on our radar screen to navigate these patients with frequent contact with patient navigators and try to get them home and use home health nursing so that we could avoid SNF, really because of the cost, not because of safety. And so I think those trends are going to continue and they're going to accelerate. And I think some of the families' fears of they're going to equate a skilled nursing facility to nursing homes that had high COVID rates. So I think we all are going to have to adopt some of the things that we were adopting anyways. And I think it's going to accelerate us into these value-based care options that we were looking at anyways.
Yeah, no, we're a very low number too. Andy, thoughts on that?
We're doing bundling, and we're just before COVID, we were moving in that direction to avoid high cost of care and so forth, and with BPCI as well. So we're doing the same things.
Okay. Let me. Sorry. Okay. The idea of reducing fixed costs. So many groups out there are small or large private practices looking at a decreased volume of surgery, needing to stay open, looking at recontracting everything from the lease on their buildings, rethinking investments in value-added technologies, looking at taking on loans from the SBA to support them in these times of trouble. What are your thoughts as CEOs of systems that need funding to keep the doors open, and what ideas you have around this, how to best respond? Maybe I'll let Andy go first because it's probably more acute there. I'll let you run your phone.
We approached our landlords, and we did get some rent relief early on because we were envisioning the budget constraints that we would have with the reduced volumes. And we also obtained a PPP loan from the SBA, And so we got that in late March, so that's been very helpful. And we did receive some HHS subsidies for stimulus payments as well, which have helped us get through the lean times here. So all those things have been helpful.
And you're going to need to get back to something close to normal within 6 months in order for that all to work out, or do you have a time frame?
Well, I definitely agree with Bruce that we're very concerned about the economy and people having insurance and so forth and be able to financially afford care, and so that's a big question mark out there. So we're concerned about Q3 and Q4 because of that.
Yeah. Bruce.
Yeah, so we took a bit of a unique approach to this. I was very concerned that if we pushed all of our expenses into Q3 and Q4 and into 2021, that it was going to be very disheartening for the docs working as hard as they could, making less and less and less. And so we adopted the policy we're calling it the quarantine of Q2. And so we've been fortunate to get federal funding, but to really try to keep the expenses within Q2 and keep the deficit within Q2 so that the docs will feel the reward in Q3 and Q4 when they work as hard as they can work and see the benefits of it and truly take a hit. We prepared everybody literally to take no income in Q2. It's worked out better than that. But we told the docs, don't expect to draw for the entire quarter unless things turn around. And so we've been fortunate that we haven't had to go to those drastic extremes, but basically thinking of taking Q2 and financing it over time, but not pushing everything to Q3 and Q4, because that's when folks are going to be working hard, hopefully with economic recovery and recovery from COVID and things opening up. I just didn't want people to work hard and make less and less each quarter.
Thank you. That's an interesting perspective. Tom, do you have any different system, but same idea?
Yeah, similar ideas. I mean, we're looking at projections of surgical volumes that are 85 to 90%, depending on who you listen to, for the rest of the year. So yeah, we're absolutely reducing costs. We've used to run all of our operating rooms on Saturday. We've closed Saturdays for the next 3 months. And so that's a savings. We've also reduced overtime, and we've had a hiring freeze. We are at a unique position. We're a very strong financial institution, but we're now facing some financial constraints. So we'll be continuing to work on that.
My next line of discussion before we go to the Q&A session has to do with technology. That is what Digital Orthopedics Conference often likes to focus on. And in the latest segment, we're going to go in to hear more about telemedicine and any other technologies that around that those platforms. So specifically, I'd love to hear what your experience was around the implementation of virtual care. At UCSF, I haven't done our numbers. We used to do, I think it was 9,000 visits a day in person with about a 2% virtual. And within a week, it went to about 6,000 visits per day, of which 60 to 70% were virtual. And then that tapered off as we reopened the clinics, and now it's dropping. It's still in the 20 to 30% range, but I want to talk about two things. What was your experience with the adoption of telemedicine tools? And secondly, where you're seeing it sort of level out as we get into the option of coming into city visits. So let me start first. Let's start with Bruce first, because I already know your answer. We've talked about this.
Our experience was prior to COVID, we were talking about telehealth and trying to get it instituted, and our docs were resisting it a fair amount. And then within 3 days, we launched a telehealth platform and saw about 8,000 patients virtually over the time frame, to where 30 to 40% of our visits were video visits. And the platform wasn't ideal, but the docs adopted it. Now that we're open with full access, we're down to 2% of our visits are telehealth. And so I'm trying to get, we have a task force looking at it, trying to get on more long-standing platform that will work better for us, because I think it's going to be part of our practice and our lives forever, and we just have to figure out where it works the best. Some patients, won't adopt it, but I think, maybe screening, maybe post-op, maybe in our value-based care patients, I think it's there to stay. And so I don't want it to go to zero, because then the docs will start resisting it again. They adopted it because they had to, and so we don't want them to fall back into their normal habits, because especially surgeons, we want to be comfortable, and they were comfortable seeing patients in the office, and they got uncomfortable, but they didn't have a choice.
Tom?
Yeah, we're moving certainly to virtual care, in particular because our Manhattan offices are very crowded, with patients. And so we've wanted to really socially distance. And so we're really trying to do at least 50% virtually if we can. And I think, as Bruce mentioned, there was a lot of resistance. We hadn't done a whole lot prior. Now people are really accepting of doing more virtual visits, and I think it's working out well. I do worry that they're going to sort of go back to the old methodologies as soon as they can, but I'm hopeful that we can maintain at least some greater percentage of virtual visits, and we'll still be pushing for that.
Andy?
I'd say a month ago we were up in the 40 to 50% range, and we use DOCSF, and it was working pretty well, full telehealth visits, and everybody was beginning to get comfortable. But now that we're back, since the first week of May, doing elective cases and so forth, the volume's been picking up, and our schedules are opening up. The patients really are preferring to come in and have a personal visit. We're seeing now probably maybe 10 to 15% of our visits are telehealth now. So it's dropped quite a bit. But our call center still encourages telehealth visits, especially for follow-ups and for things like MRI reviews and those types of visits.
I totally agree with that. I think we're going to see some change in terms of the types of visits that we see with telehealth. It won't be across the board. The new patients still want to be seen, but we'll talk more about that in next sessions as well. But I think this idea of identifying the appropriate type of visit for that kind of modality. And then, of course, people want to think of telehealth as just the video, but there's so many other elements that we can plug into that platform, especially with sensors, remote monitoring, that will make those visits a lot more effective. Over time, I think we'll see an improvement. So with that, I'm going to go to a couple of the questions that's come up with the audience. So in considering sensitivity to tests, do you affirm? Actually, I'm going to skip. I'm not sure. I'm going to ask whoever wrote that to reconfirm. I didn't understand the question, so I'll move on to the next one. If you have open elective surgery, are you seeing patients not wanting to come due to COVID-19 concerns? If yes, when would you predict normal would return? So the question, I think we sort of touched upon it, is COVID-19 has kept some people away. How long before you think people become comfortable with the level of the way we're managing COVID in this country, that they will come back to the hospital, irrespective of COVID no longer becomes an issue, becomes norm? Anybody want to take that?
It's going to be a couple of months for us, I think. I think they're coming back, but it's beholden to us to build the trust in the community and the patients. And we can only do that by having appropriate protocols for safety for the patients and reassuring them that it is a safe environment, and it's going to take a while to do that. When I say a couple months, it's just to relieve their fear, but I still think we're going to be down over the course of the year, as Bruce mentioned. And is that economy? Probably mostly economy, but it's also fear. We've got to conquer the fear.
Yeah, it may also be state by state, depending on when states lift restrictions and go, from phase 2 to phase 3. I think some people are following that very closely, and they're really not going to make decisions until they feel like their region has been deemed safe. And we know nothing's safe, but at least protected and past the risk of a big surge.
Last question. Will this, and I think this is the COVID-19 pandemic, help or hurt surgeon autonomy? This from Marty Nichols. Will the financial aspect of this event, I presume, push the surgeons back towards employment rather than independence? There's been a shift towards more employed physicians over time. Are we looking at, is going to be more pressure on the private sector? Andy, why don't you take that one first?
Well, definitely an event like this, makes it very difficult for private practice, but on the other hand, we also feel that we're more nimble in some respects and can take action more quickly because we're smaller and we have physician autonomy. So, will it have a huge impact? I can't really say. It's hard to say.
Bruce, do you have any thoughts on this?
I think that, time will tell on that one. I think the one thing that will happen from this is that we're going to see an acceleration of the shift from inpatient to outpatient surgery for electives to the lower cost setting, which will actually benefit the independent practices over the large hospital systems. It's a trend that was ongoing, but I think it's been accelerated, and this will probably kickstart it even further.
Tommy, any concluding remarks on that?
I would just say that it's the financial pressures that will win out. And I think there are going to be a number of practices as well as systems that are probably going to be very financially challenged. And so the stronger systems and stronger private practices will win out. And I think it depends on your location and the financial state as to which is going to win in each location.
Gentlemen,
I would agree.
Thank you. Okay, thank you. I want to thank each of you for taking time to be with us today. We've had a terrific audience participation. We have quite a few people joining us, and I wish you all the best of luck and be healthy, stay well. Thank you for all you're doing to keep our practices open and our doctors operating and take care of our patients. And with that, I'm going to thank you all and see you soon, I hope.
Thank you.
Thanks a lot.
Thank you. Bye.
Bye.
And with that, I'm going to bring up events. That little thing. And we'll be back with you very, very soon. There we go. Excellent. Welcome back, everybody. We're very lucky to have Dr. Bosco joining us today. He is I'll take it back. Welcome to session 4 of COVID-19 Orthopaedic Response. The recovery, oh my gosh, powered by DOCSF in partnership with the American Academy of Orthopedic Surgery and the UCSF Department of Orthopedics. We're also joined by the American Telemedicine Association and the Orthopedic Research Education Foundation. This session is titled Returning to Work Responsibly, the AOS Guidelines. And we're honored to be joined again by Joe Bosco, who joined us last time. He's the president of the American Academy of Orthopedic Surgery, also vice chairman for clinical affairs at the NYU Langone Department of Orthopedic Surgery, and professor of orthopedic surgery at the same hospital system. Given his role in New York City and given being in the Center of the United States and his role at the Academy, there's no better person that could be here to join us today to go over some of these questions. So Joe, I'm going to turn it over to you. Thank you again for joining us, and we look forward to hearing from you from the Academy. So I'm going to bring up your slide deck.
Yeah, thank you, Stefano, and thank you very much for allowing me to speak. So I know you've heard a bunch of folks before me talk about how they're coming back to work and what the process is. So, but what I'm going to spend the next, half hour or so talking about is that, we are going to survive this COVID pandemic. But what the Academy and what we're looking to do is to look at how we are going to thrive in the post-COVID-19 era. I think all of us understand that even after this is over, we are not going to be the same as we were before. Churchill said, never let a good crisis go to waste, right? So this is a crisis, and this crisis has allowed us to accelerate some of the things that we were doing before. And not only us, but healthcare has accelerated. So we're going to talk about emerging strong in the post-COVID era and quote the new normal. So, and talk about 4 what I believe paradigms, I hate that word, things that are not going to go back to normal, things which had been gradually changing and evolving before COVID, and that COVID was the accelerating disruptor that's really launched them into hyperspace. And they are healthcare consolidation, the consolidation of healthcare industry, physicians' practices, hospitals. 2 is distance learning, right? People aren't going to go, over time have been shying away from going to group meetings, and just anyone who has a kid in college or medical school knows that, they don't go to lectures anymore. They learn from a distance, and this certainly has accelerated that. Shift to outpatient care. What I mean by that is that as we, orthopedic surgeons, by and large, 90% of what we do, we don't need a hospital. We just need an OR, a clinic, and a place for our healthy patients to recover. And this pandemic has certainly accelerated that, because now patients don't want to come to a hospital either. And also telemedicine. And look, we've talked about that. I will use myself for an example. I remember in December or November in the post-COVID era, trying a couple of telemedicine things with some patients. The hardware was wonky. The patients couldn't figure it out. So after about 2 minutes, I just said, the heck with this, and left, right? But now I'm seeing 20 telemedicine patients at a time. You can talk to them on your phone. So this is certainly accelerated telemedicine. We'll have some time for Q&A. So COVID-19, how has this been a catalyst for change? Basically, in a lot of ways, it's been the quintessential disruptor. We have an unprecedented global health crisis. No one saw this coming. It's classic in a number of ways. It's accelerating prevailing trends. So again, there was a trend toward using telemedicine. There was a trend towards outpatient surgery. There was a trend towards healthcare consolidation. There was a trend towards distant learning, but this crisis has accelerated these trends. It's better patient access, safety, access to education for physicians, and practice consolidation. So first, we're going to talk about consolidation of our healthcare industry. So what is the healthcare industry? Well, it's a $3 trillion a year industry in the United States. There's providers, physicians, hospitals. There's the industry, you know, the pharma industry, the medical device industry. There's payers, you know, and commercial payers. The government is now pays for at least 35 to 40% of all healthcare. It's going up to 50% pretty soon. Employers are payers now, and new entities. What I mean by new entities, CVS Healthcare, right? Whoever thought that CVS would buy Aetna insurance company? There's all these vertically integrated entities. Walmart's getting into the fray now. So is Amazon. So these are new entities that are going to disrupt healthcare. Our $3 trillion a year business, just in the United States. So let's talk about individual practices. Well, you know, this is accelerating. The first quarter of 2020, 5 orthopedic practice mergers were in the United States. If you look at down in Florida, Chicago, all around the country, only 12% of our graduates from orthopedics are going into solo practice. I mean, think about how impossible that would be to have your own solo practice now. I mean, it would take you an hour and a half just to figure out what to do with your medical disposals, waste, with the amount of regulations. And forget about participating meaningfully in APMs and bundled payment arrangements. And frankly, if you were in a private group, and you were sort of on the fence about whether you should be, you know, sell your practice to the hospital or merge, you know, this crisis where you've gone 2 to 3 months without making any money may sort of convince you that may be a good idea for you to consolidate with the hospital, or it may not. But certainly, this is accelerating this process. And again, why so much consolidation? Well, you know, you have to negotiate. The federal government and in the Stafford antitrust litigation, you know, you can't negotiate with another practice to an insurance company or a hospital, right? If you negotiate on behalf of another practice, that's called collusion. But if there's one big practice, instead of 10 practices with 5 guys, if there's one practice with 50 guys, you can all negotiate together to get a better rate from healthcare systems and payers. And by the way, this is more important because guess what? Payers and healthcare systems are all consolidating. So you have fewer insurance companies, fewer hospitals. So you may not have, you know, instead of having 8 hospitals in your area, you may only have 2 hospital systems anymore. So it's not much negotiation. Economies of scale, obviously, you know, you get more bang for your buck in terms of being able to buy things. Stronger regulatory and compliance management. You know, the amount of regulatory laws is huge, and you really need people to help you with that. Innovation and care coordination. You know, it's impossible to be an APM or do any type of new practice, whether it's bundled cares or population health, if you're a 5-person orthopedic group, right? You need to be in a big group in order to do population health, and that's where things are going. Obviously, reduce competition. There's a Hirschfeld index, HHI, which looks at the amount of competition in the area. If it's above 2,000, it's a competitive marketplace, and they do it by summing the squares of the market share of the competitors. So if you have one person has 100% of the business, a monopoly, that's an index of 10,000. If you have 10 people with each 10%, that's an index of 1,000. So you can see the higher the index, the more less competition. And future growth opportunities. If you want to, you know, build a surgery center and move things, it's much better to have consolidation. The other way that the industry is being consolidated is the corporate practice of medicine, more and more private equity. Now, thank goodness, it's really just nascent here in orthopedic practices. But if you look at your dermatology cohorts and look at some of the dermatology literature for the past 3 years, almost 20% of dermatologists now are owned by corporations, dermatology practices. And we can go into reasons why that is, but they're not pertinent here. But you know, if you look at the dermatology literature, it's replete with references to the private equity money in dermatology, right? How about the health system acquisition? Well, frankly, you know, you want to merge with the health system. We look at that as vertical integration, which means that your practice becoming part of the supply chain. the same person that's supplying the OR and sometimes the patients, you are supplying the care. So it's vertically integration. So obviously hospitals are interested in buying orthopedic practice. Why that? Why is that? Because we make money for hospitals. Thank goodness, right? You don't see hospitals going out there trying to buy GY, other types of practices. They want cardiologists and they want orthopedics and they want oncologists, because we actually do well for hospitals. And obviously, what's in it for us? Hospitals, because of site-specific payments, they get more money for our services, which we can sort of enjoy that too, and that. So we're just not fee for service anymore. So hospitals are very much interested in acquiring orthopedic practices. How about insurers? The insurers are acquiring other insurers, right? And it's an issue, because when we negotiate with insurance companies, obviously it's easier to negotiate with 8 insurance companies than it is to only negotiate with 2 in your area. And if you're in the area where Blue Cross Blue Shield is 80% of commercial contracts, there's not much negotiation you can do. Either accept their terms or don't do any commercial patients. And there's areas in this country where it's almost like that. So that's an issue. Insurance companies are acquiring and consolidating throughout the country, and they've done a lot of studies. If you want to get bored, you could, if you have some spare time, you can look at some of these economic studies that they've done. And when insurance companies consolidate or hospitals consolidate, 2 things happen. 1, guaranteed the prices go up in that region. 2, because there's less competition. And 2 is that quality doesn't improve. May stay the same, may decrease. But certainly, if you look at the literature on hospital consolidation and insurance companies consolidation, quality never improves. Or there's been no study to show that product quality improves. But certainly costs go up. So, and if you're a value-based person, that Michael Porter, value is quality divided by cost. And if your quality stays the same and costs go up, guess what? That's less value. And the FTC, Federal Trade Commission, that looks at these consolidations is acutely aware of that. So, needless to say, healthcare industry consolidation is increasing. It involves all stakeholders, and it's hard. You can't unscramble. It's like quantum mechanics. You can unscramble the egg, but it's a 1 in 1 trillionth time that you can do it. Right? It's mathematically possible, but highly improbable if you're into quantum mechanics and Boltzmann stuff. But basically, once these consolidations happen, go in the opposite direction, right? So we need to be aware of this. And again, the financial stress caused by the COVID pandemic is sort of weeding out the weaker folks, and that's leading to hospital consolidation and also practice consolidation. Okay, how about distance learning? That's not going to go back either. We talked about that obviously there's been a slow trend, or maybe not so slow, to distance learning. With the advent of video capabilities, the idea that you have to fly 3,000 miles to sit in a classroom to hear someone lecture of 1,000 people is ludicrous, right? It's an anachronism. Obviously, if you're in a lecture, if you're in a room having a 2-way conversation with a teacher that you can go back and forth with 5 people, yeah, it's probably better to be there in person. But you're in a lecture hall of 1,000 people watching a person give a PowerPoint lecture, you might as well be 3,000 miles away. You don't have to be in the same room. And obviously the Academy has looked at this, and that's an existential threat to our annual meeting. So we're incorporating distance learning in here. Now, what's happened is that the COVID pandemic has increased this. I mean, for instance, I have at NYU, I have a travel ban. I can't go anywhere. I haven't been able to go anywhere for 3 months to go to any meetings. And you know what? I mean, everyone on this call, just think about when they think is the next time they're going to be sitting in a classroom or lecture hall with 1,000 people, arm to arm, seat to seat, right? That's not happening anytime soon, whether it's because you can't travel by a plane or you don't want to be in a hall with all those people. So this is really accelerated distance learning. And so what has the Academy done? Well, we have our learning management system. And in this slide, the diagram took me about a minute to figure out. You guys are much smarter than me. But in blue, 2018, the amounts of hits to our site. And on the bottom is the months, right? and so the time of year. So there's a diurnal rhythm to when the hits we get. But you can see every year it's more and more at the same period of time. In 2020, it's been accelerated. So 2018, 2019, a slight maybe 10% increase. 2020, pandemic, probably about a 300% increase. So again, this is a classic graph of, okay, it was gradually increasing with the pandemic, it's accelerated it. And, you know, look at our resident board review course and prep course. We said people fly in 4.5 days, they would sit there in a classroom, they heard lectures. Now we've done this completely online, and guess what? People like it. It's highly rated by the residents. They, you know, and now you can replicate some of the intimacy you get in a small classroom by utilizing video chat and video conferencing. So it's actually worked very well. So again, the academy and other educators are glomming onto this pretty quickly and figuring it out. So how about next year? You know, I mean, again, we had to cancel this year's meeting. Next year's meeting is in San Diego in March. I mean, you know, the California has to be at level 5 for us to have this meeting, and we intend to have it. But, you know, so we're going to incorporate a lot of distance learning in this meeting as well, just to make sure if it doesn't happen, we can do this. But it's very important and will continue to be important for us. So, you know, basically we looked at distance learning, we looked at practice consolidation. And again, distance learning is not going back. I mean, it's just going forward. How about shift to outpatient care and shift to ambulatory care sites? Well, you know, in New York, I'll just tell you the story is that now that we're going back to doing elective orthopedic surgery or non-essential surgery, whatever that means, you know, we have patients that we looked at about 800 patients whose total joints were canceled during a 6-week period. And we contacted each of those patients, and guess what? A third of them don't know when they're scheduled for surgery. A third of them wanted their surgery but didn't want to come into the hospital, right? So you know, we've done outpatient total joints. We're doing a lot of outpatient surgery, and you know, there's been some drive from the patients, but a lot of patients need convincing. No, you don't have to stay in the hospital. But now they don't need any convincing. They don't want to come into the hospital. So again, there's been this trend that was driven by physicians and not patients prior to COVID about doing surgery at surgery centers. Why is that? Because we all know we own the surgery centers, right? And we partook in the facility fees, which in many times were more than we got for a surgeon's fees. So it's helped us. So physician, and guess what? It's patients like it. It's safe. It's better for patients. And it's financially advantageous to us. So the physicians were the ones primarily driving this, taking the patients out of the hospital settings and put them in ambulatory care centers. But now with the fear of COVID and fear of coming to the hospital from other diseases, you know, it's basically people don't want to come to the hospital. I mean, listen, I don't remember one patient ever telling me, I don't want to come to the hospital because I'm afraid of getting C. difficile, right? But you know, now they're afraid of getting COVID, which is worse, obviously. So obviously the ASC market's going up, and again, that will not unwind either. There's a bunch of new ASCs being opened up. Spine surgery, you know, because of our techniques, refining our surgical techniques, our anesthesia colleagues refining their anesthesia techniques, minimally invasive stuff. We can do more and more cases, you know, as outpatients in surgery centers. I mean, look at it. I'm an old guy. I remember when I was a resident in the late 80s, early 90s, patients would come in the day before for bunion and stay 3 days. Hip replacement, they'd stay 2 weeks in balanced traction, you know, trying not to get a blood clot. I mean, nowadays we're doing outpatient hip replacement. So more and more stuff we're doing as outpatients. You know, rotting femurs, they stay 1 day and they're going home. You know, I still remember treating femur fractures in traction for 3 weeks, so 4 weeks. So it's a new world, Tevye, as they say, and it's good for our patients and it's good for us. And now it's accelerated because patients are eschewing hospital settings. So again, this is something that we've been looked at. Trust me, other people in this country have looked at. You know, people are building. You know, the academy is actively working with state societies to get rid of certificate of need regulations in many states, because basically those are certificate of need. A lot of time is hospitals trying and can control, privately owned ASC, so they get to keep all the business. And, in certain states like New York, you have hospitals which are big employers, and they team up with unions. And so the hospital, when it has a union on its side, that's a very difficult collaboration to fight if you want to build an ASC. I'll just tell you, it's very difficult. But we're working to try and open up ASCs, let our members do it. And physician-owned hospitals, the same thing. This is classic. Now, for years, physician-owned hospitals, they were grandfathered in to treat Medicare patients, but the newer ones couldn't. But now with the COVID pandemic and the lack of beds, guess what? Physician-owned hospitals can now take care of Medicare patients. And we're hoping that when the pandemic ends, that is still allowed. So we're working very hard to make sure. So, there's pros and cons, obviously, but of surgeon-owned centers and outpatient arenas. But, it doesn't make any difference what the pros and cons are. We know that basically more and more patients are going to have their orthopedic surgery at outpatient in the ambulatory setting, whether it's in the hospital and go home the same day or at a freestanding ambulatory center. So again, in our patients here, a lot of them, we have an ambulatory center, we have a hospital. A lot of our patients have told us, I'll have my surgery, but I don't want to go to the hospital, even if going out the same day, I want to go to the ambulatory center. So it's been eye-opening for us, and frankly, not surprising. Okay. So I want to end and spend a decent amount of time talking about telemedicine, because I think of all the topics we've discussed, telemedicine is the one that's really been basically blown up, and accelerated, and it's not going back, right? So, it was one of the things which we really, really worked to do with our advocacy efforts, and part of our academy advocacy efforts, we're working with Washington to reduce the regulatory burden on telemedicine and telehealth. Now, 4 months ago, when I tried unsuccessfully my first telehealth visit, you couldn't do a Medicare patient, and you couldn't take care of a new patient, and it was a commercially insured patient. You may or may not get paid, and you were probably getting paid at a lower rate, and they couldn't be in the same. They had to be in the same state, right? You had by the way, you had to use a platform like on Epic or something like that. You couldn't use your cell phone. It had to be video, and so it had to be the secure platform. So you had all these regulations. And so now, fast forward 3-4 months from now, I can this is what happens to me not frequently and other people. You start off on your Epic or your platform, the patient can't get in, then you say, okay, just call me on my cell phone, your Medicare new patient. They call you call them on their cell phone, you go, can you do, FaceTime? And they're like, well, I have an Android, I can't do FaceTime. Then guess what? You do a audio one, and audio is just as good as video, and it gets reimbursed, and it's allowable. So it's gone from no Medicare, only established patients, to new Medicare patients. Doesn't make any difference what state they're in. You could do it on your cell phone. No, you can't use a third party like Skype or these other things, because there's a question of security. But you can get on your cell phone and do it. Can't be any easier, right? Can't be any easier, even for an old guy like me to do. So, and again, and guess what? Patients, again, this is by patients. They like it. Don't look at, you see a workers' comp patient every 5-6 weeks, because they have to come in and see you, and even though nothing much has changed, they could just call in. And my favorite, one day I want to write a book of telemedicine, anecdotes, but I'll give you two. One is that, you get to see a lot. Patients are comfortable because they're in their own home. You get to see a lot of interesting things, right? But my most interesting thing was a guy that was a heavy machine operator, was working a crane, right? And he was back to work after years after his shoulder surgery. And so I'm just doing a checkup with him, and he's driving his crane when he's talking to me on the phone. Forget about driving a car. He's like doing the machine. I hadn't watched a video like that since my kids were like 3 years old. They like to watch construction videos. And I'm like, dude, are you actually operating this crane, and he was happy. He was back at work. You didn't have to take a day off of work. I mean, it's great. So before COVID, like I said, you can only do established patients. You couldn't do audio only. You can, if you did Medicare, patient could not be at home. They had to be in another hospital or a Medicare location, Article 28. You had to have a license in the state they were in, and the patient had to come from a low resource area. And it had to be real time, which they still need to be synchronous. And you can only do it every week or two. So that was a big deal. And the bottom right was the OIG was looking at these things in 2018, and some people got in trouble for skirting the laws and not taking care of these regulations. So you could get in trouble for Medicare regulations, and that's trouble damages from the government, which is not great. So that's before COVID. So what's happened? Well, there's something called 1135 waiver, which allows in time of a public health emergency, a PHE, for the CMS and head to make waivers of certain regulations. And so these waivers were made in late March, but they were retroactively effective to early March. So remove state licensing restrictions. That means for Medicare, because Medicare is the only thing the government can control, I could see a patient in Georgia, even though I'm licensed in New York. I don't have to worry about being licensed in Georgia. There's no cost sharing or facility fee. Used to be that Medicare patients, as I said, they had to be at a Medicare facility for them to do calls, and the facility had a facility fee. No more. There's a time between. You can remove the time between visit restrictions. So theoretically, I can do a video, a video telehealth visit with a patient. 2 days later, they get their MRI. I can call them or do a video chat with their MRI, showing their MRI findings, and I get to charge for both of those things. So there's no time restrictions. There used to be. It can be a new or established patient, and the rates are the same. And guess what? You can do audio now. So you can just call them up on the phone. How many times have we called patients on the phone to talk to them anyway? So it can't be any easier. And they can do their consent at the time of the visit. They don't have to have a consent already done. So they've taken away a lot of restrictions. And patients like it. They don't have to come in a crowded, how many of us have taken our kids to pediatricians back in the day, and we're sitting in this office with, 50 other sick kids. They say, if your kid is sick, walk through the lobby and go to this one area, right? So you're walking through the lobby with all these sick kids, and you get sick yourself, and your kid gets sick. Well, the same thing with COVID. So patients like this. It's very good for them. So Medicaid, the federal government controls Medicaid somewhat, not as much as Medicare, but they've also worked with the states to loosen up the Medicaid regulations as well, right? Audio only new patients. Many states have done this. Each state has different rules, but they're working on to standardize the rules as well. So what are we? So we've gotten pretty far through our advocacy efforts and the advocacy efforts of many others, not just the AOS, but most providers are aligned on this, right? So again, we want to retroactively align all dates of policy to March 1st, and you may have some new codes so we get reimbursed. How about commercial payers? We want them to do the same. Right now, the government or the academy, no one really has much sway over commercial payers. But certainly, we want to be able to do video. We want to be able to take telehealth with our commercial payers as well, and actually get paid. So, and the same thing for E&M codes, make the audio codes the same thing as the audio visual codes. But again, and another thing is that, and what are the updates? Again, policies are now retroactive. We're getting paid the same whether it's video or just audio. There's new codes. So all these things are making it easier and removing the regulatory barriers for us to do telehealth. And when you combine the regulatory relaxation with now being driven by patients who want it, right? Patients love being at home talking to their doctor for the most part. And two, what about us? Well, when we go back to the new normal, and start seeing patients in our office, we're going to still have to do social distancing. So the idea that we have an office full of 50 patients or 40 patients waiting because I was held up in the OR or whatever, had a meeting, and now I walk in, the office is full of patients. That's never going to be allowed again, right? We're going to have patients are not going to be waiting in an office. We're going to be limited to how many patients we could see every hour, and so if you're limited to how many patients in person you can see every hour, then you need to get a better way for these patients to get access to care. And the way they're going to get their access to care is by telehealth. So it's being driven by us, by patient satisfaction, which is high, and by safety issues. So again, we're going forward with this. And the most recent thing, the latest 1135 waiver, as they call, is allow different practitioners. So you could do a clinical psychologist. You could tell your clinical psychologist about your mom via you don't have to see them in person. You could do it on the phone. You could you can do telehealth for PT, virtual physical therapy. That's a big boon for us, because now physical therapy, if you're in a bundled care arrangement, physical therapy is a cost center, right? So if you do virtual physical therapy, that's less expensive, saves money, adds value, because the patient's at home. They don't think about it. You have a patient that you just operated on with a knee replacement. They have to go to a physical therapist, get in a car and drive to a physical therapist. That's a lot of hardship for the patient. Might as well just do the therapy like a Richard Simmers video or something like that. Do it at home. We're it's like the teleconization of physical therapy. That's what we're looking at, and patient satisfaction is very high with that. So, and that's been great for us too. And if you happen to work for a hospital, guess what? They get to do their service site billing as well, pay a little bit more, even in a site of service fees. So the hospitals are happy too. So here's our obviously all these changes happen very rapidly, and many of our surgeons are on top of it. They don't need this, but some of them need to be sort of led through it, and so we have a lot of resources on the Academy website, the COVID resource site, that talks about telehealth and how you step-by-step process on how you can incorporate telehealth in your practice to maintain your patient flow and allow you to take the type of care for our patients that they deserve. So again, and it's very helpful. So with that, I could take some questions.
Absolutely. Thank you. That was pretty remarkable, and shows us exactly what the association is doing for its members. And actually, interestingly, our next speakers are the American Telemedicine Association. There's definitely a lot of opportunities for the two societies to collaborate in some of these issues, because at the end of the day, these waivers, Dr. Bosco, they're not changes in the law, right? So there's a possibility for these to kind of revert if we're not active in Washington.
Right, when the public health emergency, whenever that get declared over, then these 1135 waivers can go back. But again, it's like unscrambling the eggs. We have the perfect trilogy. Patients, there's huge amount of patient satisfaction, and we always complain about Medicare for a variety of reasons. But one thing the politicians and Medicare pays attention to is their patients. So as patients like it, they're not going to go back. Senior citizens tend to vote, and those over 65 vote. If they like something, it ain't going back, right? And so not only do they like it, it's better for patients because they're not getting sick, and it's better for us. So you have three things going for it. So I can't imagine us going back to the way things were.
Which actually is a question that Dr. Paget had. Do you ever expect the telehealth deregulation to be permanent? Again,
I do think that that many of the rules that have been relaxed will not go back to normal. Which ones, I'm not Nostradamus, but I think that, and by the way, the Academy is working very hard to make sure that most of these things aren't going back.
Question from Noam Cohen. Have you witnessed new habits like asking the patients to send images and videos before their telemedicine session? I presume this is in your practice, which is tied to another question, which is when you last spoke to us, you were doing about 15 patients a day in telehealth, and is that continued increase or decreased? So two arms of the same question.
Well, I'll answer the first one. Is that I will tell you that for new patients, that you're trying to see, that's been a gap in the technology. It's very difficult for new patients to download their images into our file if they don't come. mean, we're in Epic and most systems. If the patients come to the office, you can physically download their stuff into their chart. But we're not great at remotely downloading their images, right? We haven't figured that one out yet. But I'm sure that when I talk to you again in 6 weeks, we'll have that figured out.
Yeah.
But that is an issue with certain new companies, right? And look, don't use me as a barometer. Or maybe you can use me as a barometer because I'm the lowest form, right? So if I can do it, anyone can. So I'm doing more telehealth visits. Well, I will, and again, no one cares my personal practice. But when I've talked to people around the country, I will say one thing, and I've seen this too, and I'm sure our audiences will agree. When you sprinkle in telehealth visits with the rest of your patients during the day, it's not great because they're on the phone for 15 minutes waiting. So what my colleagues that have this down will do their telehealth visits at the end of their day. Right, so they'll do their in-person visits, and at 1 o'clock or 2 o'clock they'll stop and do their telehealth visits. So they go from patient to patient, because it's hard to see a patient and get on the phone and see it. Because the other thing is, it takes a couple minutes to get the telehealth medicine up and going. Right, they got to dial in. You have to dial in. There's some futzing around, as we say in New York, a little bit. So it works better, more efficiently if it's done, right in a row. And as part, I will say this. As part of the reimbursement, people are like, well, if I get a bill at 99213, I need to have 3 things on my physical. Well, obviously telehealth, you're not doing a physical. So what the government has done is they changed what you have on your what you document. It's changed to you have to document the amount of time. So you can still charge for a high-level consultation or a high-level office visit if you attest on your note that you spent a half hour with the patient, or 15 minutes, or whatever it is, instead of documenting the H&P, a physical exam that obviously difficult to do over the phone.
You started by talking about distance learning, a topic near and dear to our heart. We're doing distance learning right now. And the Academy embracing it. You guys have done an amazing job, and I love the data you showed of the increase in access to these technologies. CME, is that going to be an issue, granting CME over the web?
No, it's not an issue. I mean, a lot of CME courses are over the web. In fact, one thing I'm most proud of, and our Academy has done, and kudos to our staff, I had nothing to do with it, is it was a big deal to cancel our meeting, and within a week after canceling the meeting, these guys were already figuring out how to have a virtual meeting. All the content, all the posters, all the lectures, most of them, they're audio video now. You can go there and you get your CME. You can get your 38 hours. You can get whatever you want, your CME, because we need to do CME, that's for sure. So it's available from the Academy, and because we know that's a big service we require our folks. And for those out there who care, you could put your these Academy presentations and talks on your CV as well.
Oh, that's right. A very good point. I thought about that. And actually, this
on your CV not give you a raise. Tell Val he's got to give you a little raise because your CV is a little bigger now.
Fantastic. He's actually on the line watching. So thank you, Joe. I'm going to sort of call us in, but I'll tell you on the technology side, a very interesting thing that's happened. There's at least one group in Europe that's trying to build out a blockchain to connect the track CME. It's immutable, it's trackable, and it's a perfect way. It's a perfect application of that technology for CME, and maybe that's something the Academy is thinking about doing as well. Like I said, blockchain technology is really a powerful tool for tracking CME. And with that, I'm going to say thank you. Thank you again for going through the long list of things the Academy is doing on our behalf, and it's successfully so. And I look forward to. Again, the ATA is coming up next, and I think there's an opportunity for us to work together with them.
Listen, it's my pleasure. Congratulations on organizing these really meaningful meetings. I mean, all these people you have, it's a great job, and I'll be listening to the rest of the speakers. Thanks, guys.
Thank you, sir.
Hello and welcome to DOCSF. We are experiencing the orthopedic recovery. And in particular, we're exploring a lot of different features of what is required to get us back into our practice and taking care of delivering orthopedic care. And so we started out early this morning taking a look at the virus and taking a look at the workforce, the impacts. And now we're going into from the standpoint of we're using a lot more telemedicine, telehealth, digital tools. And to discuss what that looks like, I am so glad to have Ann Mon-Johnson. She is the current CEO of ATA, formerly known as the American Telemedicine Association. She's an entrepreneur. She's a rebel. She's also, we will say right now, a futures forecaster. I think you're going to have a lot to say about that, Ann. And then Joe Kvedar. Joe, you are, first of all, what people may not recognize is because they know you as an author and an evangelist for using telehealth and telemedicine, but you actually are also a professor at Harvard in dermatology, right?
Correct.
All right, so thank you again for joining us today. Let's just dive right into it from the standpoint of, since the pandemic, there has been an awful lot of change. And particularly what we've seen is the use and the exploration and the acceleration of using telemedicine. And why don't you start us off, give us a sense of, you're sitting in this really interesting position because you're seeing practitioners, all the different disciplines, all across the country, urban centers, rural centers, and all of a sudden, whether you like it or not, because of the stay-at-home orders, the reduction in surgeries, the cancellation of all elective, we've had to do things a lot differently. What have you been hearing?
So I think from the practitioner or the clinician's perspective, what we've heard is a huge uptake. So when I first joined the ATA, I think adoption engagement by clinicians was pretty low, maybe in the 10% range. And more recently in research that the AMA did, just pre-COVID, they looked at adoption at about 28%, which was already a big improvement over prior years. But now what we're seeing, anywhere from 60 to 90% adoption and use of telemedicine. And of course, that varies by specialty, but I think that the adoption rate has been pretty significant. What that's going to look like post-pandemic, I think remains to be seen. It's probably not going to be as low as 28%, but it's probably not going to be as high as 90% either.
Yeah, can you give us a sense of pre-pandemic, what was we'll say that usage rate? Would you want to say usage as opposed to adoption? Because adoption says that you're in that phase of bringing it on board. So what was the baseline use?
So again, I think it was more in the 14% range, up to 28% just pre-pandemic. And of course, that varies by specialty. Joe, you probably have some observations on that too, right?
Yeah, well, specifically orthopedic care, what was the usage rate there?
So I don't know specifics on orthopedics. I know the more procedural specialties have traditionally done less. It makes sense because their core business is done in the office. But I think many of them have learned during this crazy time that pre-ops can be done virtually, post-ops can be done virtually, physical therapy can be done virtually. So there's a lot of ways to do it. And what we end up seeing is people rethinking how they use their brick and mortar in the office and what's more efficient to get done virtually and what's better to make sure that the people coming in the office they really need to, et cetera. So that's kind of what's happening now, I think.
Yeah, so Ann, from the standpoint of, and Joe, I should say, you are president-elect. So it's good to have the two of you here because you're overseeing and hearing what's happening right now. And Joe, you better be ready because it sounds like it's getting a lot busier. Right? Is that true?
Oh yeah, sure. I've got my gloves on.
Yeah, good to know. So Ann, let's talk about how quickly this ramp up has been. And also, what were the things that people were learning? What very specifically did they see? And let's keep this, again, to orthopedic care. What were some of the places, the very first, because everybody right now in orthopedic care not everyone, I should say, the vast majority of orthopedic care, they have had to delay, and they really haven't been having a full cycle of what care looks like, unless it was trauma or, you know, some things that were needed to be addressed during COVID. But during this period of time, which problems or which part of the care journey have they seen using telemedicine, telehealth? What aspects is best, have they found the best results with?
So I'll just say what I've heard, because I'm not a clinician and rely on Joe for part of this, but my impression is that, as Joe indicated, the post-operative checks have been pretty effective using virtual services. So just as we're doing now, we're talking to each other using a video element, video audio element, or synchronous communication, and that's been pretty effective. I will say that I've had personal experience with physical therapy. I fractured my shoulder pre-COVID and did all of my rehab with physical therapy virtually. And I would get a text every morning telling me what exercises to do. So that sort of management, ongoing management of services, I think has been effective. And there's been a huge uptake in that. How clinicians or orthopedists have been able to engage with patients, I suspect, has been the same with others who've been very procedurally based in terms of helping them manage their pain, helping them manage their condition as they wait to be able to have a procedure. And again, Joe, you're the clinician in the crowd.
You're the clinician. What
No,
are
I
you
think
hearing?
we've pretty much covered it on the procedural side, but proceduralists do a lot of other things. They usually are quick to tell you that they're doctors. They're not just proceduralists, that they take care of patients. And orthopedics, of course, is not just operations. There's a lot of other things that go on. And anything that doesn't require you to touch the patient to make a decision, whether it be a diagnostic or therapeutic decision, it can be done by telehealth. And people are learning that every day, real time as we speak.
Yeah, so that virtual, being able to check in virtually. So one of the things that has been very specific to orthopedic care was the high rate of cancellations, so or rescheduling. So so clearly they had been cleared for their procedure. There was a condition going on. So we're talking a little bit more about the post-op, and yes, you can do rehab. What are we doing in the interim from the standpoint of managing a situation that there was a surgical need? How are we using the digital tools, the virtual environment, to address taking care of people while they are waiting?
Joe?
Well, again, I not being an orthopedic surgeon, I can only speculate, but if it involves a conversation about pain control, if it involves a conversation about range of motion, if it involves something that's mitigating while we wait for the OR time to come about, and of course a lot of these are elective joint procedures that, even though the person might be experiencing symptoms, can in fact wait. So it's really, I think, about coaching them through how to better manage their pain meds, how to better manage their range of motion, et cetera, their exercise level while we wait for those operating rooms to clear.
So it's really just being in touch with them. And I think one of the things that we've heard in prior sessions was the importance of building trust, that for many patients, now we're thinking about their surgical schedule, they are looking at this saying, what's my risk of picking up contracting the virus? So
sorry, go ahead. I would just say that the importance of building trust is predicated on having contact with your patients. And one of the things that I've heard pretty consistently from physician practices, not just orthopedists, but how pleasantly surprised patients have been with the outreach of the physician office.
Yep.
And they were under the assumption that because their procedure was canceled, that everything was shut down and they would not have any contact. So that simple act of picking up the phone and checking in has been incredibly powerful and very, very impactful.
So the value then of the video visit in that interim has been incredibly important as far as not only maintaining their level of physical well-being, but I think it's done a lot for the psychological well-being. And we know definitely that you recover better when you are in a better state of mind. And certainly the anxiety on every level has gone way up. So the video visit, that contact, does a lot to alleviate the psychological stress and manage anxiety and help them to be better prepared for their surgery. So one of the things that, we talked about having low adoption rates. One of those reasons for the low adoption rates is we had a lot of rules and regulations around how you could conduct a video visit, what the financial model looked like, who was qualified for that, what plans were covering. This there was this rapid change in, is it relaxation of the regulations? Was it a lack of enforcement? And you've been over there from the standpoint of thinking about government affairs and what those policies look like. So can you give us an understanding of what transpired that allowed us to move so rapidly into adopting virtual care?
Well, there was a series of waivers that were issued, and that was really important in terms of attacking, if you will, what were barriers to getting people care where and when they needed it. And so the traditional barriers in telehealth for widespread adoption have been licensure, it's been reimbursement, it's been connectivity, particularly broadband. And basically 2 of those issues were, over the course of the past several weeks, have been mitigated. And so that has really created a huge surge. I think, it's safe to say that the 60 to 90% engagement or usage rate by physicians is driven in part because there's been a sense that they're going to get reimbursed. There's also some things, though, that we're concerned about. So, for example, the fact that there was enforcement discretion associated with HIPAA and the exchanges between clinicians and patients. We've been very concerned as an association and have taken a stand that said, just because you've adopted things quickly doesn't mean you should cut corners in quality. And so we're very concerned about that. We know our members are being very vigilant. Our members are very diverse. They include delivery systems, medical groups, academic medical centers, as well as solution providers and payers. And so it's been really terrific to see the response of these folks and recognizing that they do have to pay attention, even to privacy.
Well, I was just going to say there's a lot of layers of privacy. There's the data privacy. There is, during the interaction, the encounter, how do you make sure that that connection is secure? One of the other things that's come up that I hear across the board is that some of the challenges with the adoption is over on the patient side. Do they have access to the internet? Do they have the right type of tools? So as an association, Joe, let me ask you to comment on that. On that experience side, the very practical, what have we seen that was working, and what were the things that got in the way of it being a successful encounter on both ends of using telehealth?
Well, what's working is and it is extraordinary. I was worried when we started this journey in mid-March that we're going to have a lot of hiccups. I mean, we brought 1,000%, several 1,000% increases in all the delivery systems. The one where I work, we did 1,600 virtual encounters in February, and now we're doing 60,000 a week.
Wow. Okay, that is a huge, the magnitude, the scale.
Yeah. All over the country, and yet all I really hear is positivity from both patients and clinicians. So I think kudos to all of our IT support and just people's willingness to say, we're going to try something new, and we're in a pandemic. So I would say that I would say as we come out of it and think about how we integrate telehealth into our physical practice, because the physical practice was never meant to go away. There's always going to be need for some patients to come into the office for certain things. We're talking about like having separate half days for telehealth. We're talking about have providers to conduct telehealth half days from their home so that we can use the brick and mortar differently. So that's a lot of what's going on now, is how we think about those And honestly, other companies and other industries have done this a decade ago, where you see companies like Uber and what have you, where they've thought about how to integrate a digital experience with a face-to-face experience. We need to go through that now in healthcare. As I was saying before we came on, it used to be viewed as a curiosity by most doctors. Now they've experienced it. Their patients want it more. And so we've got to sort of come and say, all right, how do we clarify now what's best in office? How do we clarify how to integrate telehealth into these practices, et cetera? So it's a very exciting time for that.
Yeah, and you had mentioned that, that we had this huge rush. And sorry,
right.
you were going to
Well, I was just going to say, I think the other thing that's worked has been sort of the broad range of services that can be used. So audio only, for example, the fact that people can just use their phone makes it incredibly easy for some cohorts, some populations who perhaps had not been versant with Zoom or whatever the technology may be that incorporated video and audio. So the phone only, I think, has been very beneficial in getting people to interact with their physicians. So I think, you know, what I find interesting in this is that what really has changed with telehealth is that it was viewed as sort of a convenience factor, and it was used primarily by young millennials, you know, younger folks who may not have a primary care physician, and it was just a matter of convenience. And now I think it's much more a matter of life and death for most people. And I think that the other thing that's really worked well is the whole emergence of asynchronous methods of communicating. And the fact that you have companies that provided services free most of the time, in fact, all the time, I think, that enabled a consumer to go and look and answer very specific questions to determine whether or not they were likely to have the virus, and how do they self-care. And what these asynchronous tools enabled was a huge ability to scale and to be efficient in a way delivery systems would not have been able to do otherwise. We have companies who are members who've done 75,000 asynchronous visits a day.
Just so, I mean, from the standpoint, are you referring to the chatbots where we're using symptom checkers?
You're using that, but you're also using interactive assessments or questionnaires. It's a guided conversation.
Yeah.
So it's not nearly as cold or fruitless as just a chatbot. And I think it's been really remarkable how those have been really used extensively by consumers and by clinicians.
Well, I was just going to say, one of the things that I found really interesting on how we're managing prevention of transmission. We want to cut down transmission, and transmission has been a lot within essential workers, many of whom are clinicians. So actually the telehealth piece and the symptom checkers, the asynchronous, is let's check everybody before they come into work, before they come into surgery, before and after. So in the childcare centers, so many of the hospitals have put on-site childcare centers or areas, but they are addressing the needs of the childcare needs. So whether it's that clinician, and we're seeing that more in practices where they're using the asynchronous to determine if somebody is, appropriate for coming into work or appropriate for coming in for an in-person visit. So they're using that chatbot before they even, it's a hybrid. It's not an either or. It's just integrated into the entire care journey.
Experience. Yeah.
Yeah.
Right.
Yeah.
Right.
So,
and I think the reason why that's important is when at the ATA, what Joe and I talk about is that, pre-pandemic, we had a shortage of clinicians. We did not have enough clinicians to take care of our aging population with multi-chronic conditions. And this is a problem we're facing worldwide. And so if we use technology to just replace a face-to-face visit, we will have sold the whole thing short. And what we're seeing now is the ability for technology and telehealth to help reimagine care and how care is delivered. And so I think if you approach it from that vantage point, you find it more as a way of augmenting and supporting your practice, your interaction with patients, as opposed to a threat.
Yeah. So from the standpoint of thinking very specifically, we were talking about some of the regulations. And I remember several of the press conferences where Seema Verma was there. And she very specifically said, whether it's your phone, FaceTime, Zoom, conference call, she really opened that up. And we had to at that moment. What are your concerns? You know, we had this flood of usage and people were experimenting it. The first thing we need to do is be safe on many levels. And I don't think we're going to see some, pullback on that. As we get better at this, what do we need to be concerned about to be safe so that the regulations that are going to be coming in place, how do we want to have regulations that allow us to be flexible and to explore new things and do it in a safe way? Have you got some thoughts about what we need to be thinking about and the language that we use as members of the orthopedic community to have the right things in place?
Well, I'll take a shot and show, because we've worked very closely on this, which is the statement that I mentioned that the ATA came out with that said, even if you're moving fast, don't cut corners. So this so-called genie out of the bottle, yes, it means that there's a lot of different ways that people are operating, but clearly some are not appropriate. So FaceTime, for example, or Facebook Live, or TikTok. I don't even know how you use TikTok, but still.
I've seen some pretty effective orthopedic surgeons doing that with kids, getting them to dance, as part of their therapy. Yeah, and I think that let's take a look at TikTok just for a second.
Okay.
Where I've seen the orthopedic community, well, actually, the community that's taking care of the millennials and younger, that's who's on there. And so from the standpoint of getting them to be more active, to understand better health behaviors, that's where that segment of our population, that's where they spend their time. So I think figuring out how to use that. But yeah, I've seen several of the orthopedic surgeons with their recovery for young kids, they get them up dancing, and it's been, well received.
They're meeting their customers where they are, which is really important. And I think that's the big change that happened here, is that we're meeting people where they are.
Right. And it feels like the vast majority of the change has been over on the provider side, actually. We've actually, customers have been clients, patients, depending upon where you are in the care continuum, they have been using digital services for a lot of their life. And I think many of them have been interested and eager for their healthcare to transition over there as well. And so, Joe, my experience as a clinician is my patients have been ready for this. Some of my colleagues have not. What have you seen?
Yeah, I mean, in about 27 years of working in the space, I probably could count on one hand the number of patients who had some challenge, and other than I can't get the technology to work right, that's still something we need to get better at, is making it so dead simple for all parties to connect. But other than that, once the experience is had, that you get this magical, I think it's magical, coalescence of access, quality, and convenience. Everyone's happy, everyone wins. And I think that's really the way we have to view these interactions, is when we can see those three things coming together at once, and we know we've done a good job. You have to have quality. Ann just mentioned that, and I would underscore that 10 times. We're not talking about cutting corners. But there is something to be said about being patient-centric, about the fact that patients can get care where they are when they need it. Interestingly, one just quick example is during this time, and my colleagues that I've talked to all say the same thing, the no-show rate for appointments has gone way down because you're catching people when the appointment is in their own home. It's simple thing, but that used to drive people nuts, as you know, the no-show rate, and it's almost zero with virtual.
That's, I was gonna say, the other thing too, that I was in another conference and we were talking about the number of cancellations, super high, and then trying to get the reschedule. So it was interesting that when one of the clinical staff, one of the nurses or the surgeons reached out to reschedule a procedure, that reschedule rate was up like around 80%. Whereas if it had just been, let me send you an email, but when they actually used some type of an interaction, they were, those cancellations they were rescheduled.
Yep.
So we've got several questions. One of them is talking about telehealth as a platform on which we can hang the other tools through which we can optimize the use of our electronic health records. So have you got anything to say about that, Joe?
Well, integration with electronic records is one of the important things. I think that question gets at workflow, and one of the things we used to cite as a barrier prior to the pandemic was workflow, that you couldn't, excuse me, expect clinicians to be on a platform like this and then have to change screens to look at the electronic record. This morning I did virtual visits. I launched, I think, about 6 or 7 of them right from Epic. We have integrated Zoom into Epic where I work, and it's a beautiful thing. Patients come into a waiting room from the patient portal. It feels very much like an experience that mimics being in the office. So that integration is important. And the other tools are things like devices, remote monitoring devices that can give you more information. Things like that we will continue to see proliferate because they're important for home testing is another one, lab tests that we can do at home. More and more of those will come out, and that will give us more and more opportunity to make these virtual visits more plentiful and more meaningful.
Right, and have it be an integrated experience. So one of the things that's really going to change, and we need to think about this for our orthopedic patients, is recovery. So if you've got somebody who has a comorbidity and they're elderly and they were in isolation, they're not going to be able to go directly to a skilled nursing facility or a rehab center. We're going to have to rely on remote monitoring and doing virtual visits. So thinking about that entire experience, how are we integrating wearables, remote monitoring and sensors within Zoom, as well as the EMR and dashboards, so that we know all these people that we are managing at home, how do we know who needs to be seen at what moment for what problem, or, just to check in on them, so that it's not just, okay, Monday, here are all the people that we follow up with, that it's really driven by the clinical data. Are we seeing that? Is that something to get excited about?
Well, I think it is. And I would say that the integration point is the electronic record. That's where these all come together. That I don't think, I can't say Zoom, I don't know their technology roadmap, but I doubt that it involves connecting a lot of peripheral devices. Whereas we're getting both of those integrations right now through Epic where I work. And so that indeed I can be on a video call with you, and then half the screen could show your home blood pressure readings, all in the same experience.
So we have another question. Go ahead, Ann.
Sorry, I would just add to that the whole notion of remote monitoring, the idea of using data to flag a situation before it gets really bad has something that we've seen incredible advances in terms of remote monitoring. And being able to tag a patient for a possible problem before it even surfaces has been a real advent of the use of AI and machine learning and integrating that in digital devices. So there's no reason why it's not going to continue to explode.
Well, that's one of the things that you had mentioned. I've heard you speak about this, Anne, that too often times when we think about telehealth or telemedicine, we're thinking about this synchronous face-to-face interaction like what we're having right here. But it is a much more expanded experience, and it is an ability for us to actually better understand a health problem and an illness journey. And so from that data, when we're able to actually mine that and using AI and machine learning, it actually tells us, this is the person who's at risk. And so it actually improves our care, our learning around all of that. I think you've mentioned quite a bit about how, that we think about it as the interaction, but you're really thinking about it on the back end as how we're collecting data to actually deliver better care. Have you got some examples that you've seen that you wanted to encourage us to pursue more aggressively?
Well, I just think the whole idea of people aging in place or aging home is one that really lends itself to that sort of passive monitoring. I always love the expression or the description of the beauty of an Amazon Kindle is that you order it online, it shows up at your house, you turn it on, and it works. And the bottom line of that is if you want someone to do something, don't make them do it. And so that is really the power of remote monitoring. And that's why it's so interesting to see companies like Best Buy get into healthcare in a big way, starting with their acquisition of Great Call in December 2018. So you think about, your parents, your elderly parents at home, and one of them has procedure and you want to make sure that they're okay. You're going to have Geek Squad go out to their house and outfit it for remote monitoring, and very passive, but they're going to be watched in a way that they weren't before.
That's okay. That it is dramatic. It is shifting. I mean, Joe, you had mentioned that what you were talking about in evangelizing 2 months ago, some of the presentations that you've looked at, they're dinosaurs at this point. They're not relevant.
Yeah. It seems so very quaint to go back and look at slides that I presented at the end of January. It's really amazing.
Yeah.
And what we're really focused on now is that future experience where, and I keep mentioning companies like Uber, maybe that's too abstract for people, but there are so many examples in your non-health care world where you have an integrated in-person digital experience and you don't think too much about it. And that's where we have to head. We have to we have to present ourselves to our patients as digital organizations. We have to have them properly cared for. We look forward to the day when someone shows up at the offices. Why did I need to be here for this? Right? And as opposed to everyone who shows up saying, well, by golly, I better come for that appointment because I've been chosen to come in. That means something really special has to happen here that's in, as opposed to, let's talk for 5 minutes about your last lab test and send you on your way.
So one of the other questions, orthopedic surgeons are heavily reliant on radiographs, MRI, and imaging, and less on the physical exam. So are there any technologies that are going to have, that are for us to access the imaging at the time of the telemedicine visit? Are these technologies, are they going to allow our patients imaging modalities in a compliant way during COVID?
So I'll take a crack at that. That's a very futuristic and it's a great question. And I don't know of any home X-ray devices that are on the horizon. I do know that 10 years ago we were talking about portable ultrasound, and that's now a thing. So these things that sound a little bit Jetson-esque, give it 10 years and you'll start to see it. In the meantime, the answer to that question in the current state is the integration of this into the electronic record. So yeah, the patient has to go to an imaging center to get an image done, but then when you have your conversation with them virtually, you can access that and go over it with them. And our patients increasingly can access at least the reports in our patient portal, if not the actual image.
And then another piece that's going to be so vital to care is home testing. If we've got somebody that's scheduled for surgery, we need to figure out if they are actively carrying virus. Are they somebody who is, are we going to be actually able to deliver the surgery? If so, what is the frequency of which they're going to be tested? And so where does that testing get done? So there's so many questions as far as getting somebody ready on the preoperative, on that schedule. Any thoughts about how we're going to use a telemedicine environment to achieve that goal?
I just think that the things that we try to envision now that seem too space age are just around the corner, and somebody's seeing it as a problem that they can solve. So,
that's why we love our entrepreneurs.
Yes, exactly.
Yeah.
Yeah. But Joe, you probably have more specifics.
Well, I would say, despite the fact that and it was unfortunate on every level, Theranos set us way back. And Theranos became sort of people saying, well, that can't be done. As a matter of fact, I know of several companies that can take not the tiny amount of blood, but a couple of drops of blood and do all kinds of amazing things with it. And so that's, again, as Ann said, that is literally around the corner. It's in FDA clearance now and will be in the market in the next year or two. So lots and lots of things are moving into the home. There are devices that you can take your temperature, look in your throat, look in your ear. There's all kinds of things that will enhance our ability to make a telemedicine visit a very robust interaction with our patients and obviate the need to travel.
Right. There's a Israeli company that you can actually, in this sort of video interaction, they can evaluate your respiratory rate, your pulsicity. It's just phenomenal what can be done. And
is that Title Care that you're talking about?
No, this is Benai.
Okay.
But Title Care has the devices that, again, are being broadly distributed through organizations like Ochsner Health, where you can look in the ear of a kid or the throat and determine with incredible accuracy whether or not they need to be seen or they should just jump to antibiotics.
Well, we need to wrap things up. So I think what I'd love to have you provide is, have you got some like 2 or 3 pieces of advice for the orthopedic community from the standpoint of thinking about, we've made some gains here. We are still learning. What would you it's interesting. I was going to say in the upcoming months, but things are moving so fast. It's like in the upcoming weeks. Yeah, really in the days and weeks. So as surgeries are opening, being scheduled, and we are in that recovery, and more states are removing their stay-at-home orders, and we are going to see more of this. What would be a couple of things that you would say, these are the core things that you need to pay attention to now in order to set this up and be successful and safe?
I'll start. I'll say workflow is paramount. In other words, just rethink and re-question every single thing that you have on your schedule. Does that person need to come in? And think hard about it, because the answer used to be yes, but it isn't always yes. And then that you can really start to then juggle your brick and mortar, think about how you use your non-clinical spaces, how you use your interactions with, or your telehealth interactions, and to create a really knit together experience. That's going to be the next challenge.
So every question should start with, how might we?
Yeah. That's probably true. Yeah.
Okay.
And I would just add to that to be incredibly proactive as you engage with your patients. I mean, virtual is not for everyone, just as it isn't for all physicians, it's not for all patients. And then the other advice I'd have is just to stay on top of the coding and the reimbursement, because I have heard so many stories of how challenging this is.
Yeah.
And, when you miscode, it can get construed as fraud, and that's not what anybody wants. And so it's really important to stay on top of that. We have some resources that we've posted on our website, americantelemed.org. And we just know that this is really, really important for the medical community.
Yeah. And that has been one of the major concerns. And so you guys are a great resource to help everybody with that. With that, I will just say thank you so much for joining us. And we've got all of your links that are available, so we encourage people to reach out to you. It's like you said, it is amazing, all of the partners who are coming together to really help us think about how we do this well, safely, and I would hope with joy and excitement, because it is really fun. And I think we forget that part. We're just talking about transaction, let's just get this done. But this is a lot of fun. So I appreciate your enthusiasm, and we'll look forward to checking in. Let's see, maybe we should check in next month, given the pace that we're moving at. Yeah.
It'll be a different
Stay well.
interview for sure. Yeah. Thank you.
Stay well. Keep your hands washed, and
thank you.
Bye-bye.
Bye.
Welcome to session 6 of COVID-19, the Orthopaedic Recovery, powered by DOCSF, the Digital Orthopedics Conference, San Francisco, in partnership with the American Academy of Orthopedic Surgery and the Department of Orthopedic Surgery at the University of California, San Francisco. We're also joined by the American Telemedicine Association, as you probably just heard, as well as the OREF. I'd also like to mention that a special thank you to our DOCSF sponsors. This is our second virtual event, and they were thoughtful enough to join us. Zimmer Biomet, Johnson & Johnson, DePuy, and Modernizing Medicine have all joined us and providing symposia at the end of the conference that you may want to stick around for. They could look very interesting, and their innovative solutions during this time of recovery are very useful. So look forward to joining that. For the time being, now we're at the session 6. This is the healthcare economy and what's left of it, and what to expect if unemployment does reach 20% or higher. We're joined by Dr. Kevin Bozick, who is the professor and chair of surgery and perioperative care at the Dell Medical School at the University of Texas in Austin. And Kevin's an old friend and very knowledgeable about this area. I want to thank you for coming. And you're going to do us a favor also introducing your other guest, which is Jamie Robinson.
All right, Steph. Well, thank you for including us in another great DOCSF conference. Excited to be here with my colleague, Jamie Robinson, and really appreciate the comments and the perspectives that have been shared already on the conference today. So my colleague and co-host here for this session is Jamie Robinson. I think you'll find that he's eminently qualified on this topic. Jamie's a professor of health economics at the University of California at Berkeley and has a research and teaching focus on clinical innovation and the specialties and facilities that employ them. He has a long-standing interest in orthopedic surgery and has worked with CalPERS on their reference pricing initiative and worked with a number of different organizations on bundled payment initiatives related to orthopedic surgery. So we look forward to hearing his perspective. So Stefano asked us to touch a little bit on what's going on in both the U.S. and the global economies in response to the COVID-19 pandemic. So let me just start with a question, Jamie, that's on everyone's mind, and that's the economic recovery. So maybe you could start by telling us what the current state of the U.S. and global economy is coming out of this pandemic.
Well, first of all, thank you for inviting me to join. It's great to participate and we can all speculate together. Anybody that knows the future should rearrange his stock portfolio and buy an island in the Caribbean. I think the best guesses are that for the U.S., they were expecting 2 to 3% GDP growth this year, and now they're expecting maybe a 3 to 5% GDP decline. That's called a recession. And the real question is what's going to be the shape of the recovery. And the way that economists talk about this is that you can either have a V-shaped recovery, an L-shaped recovery, or a U-shaped recovery. And I'll say, what is each of those? And then we'll speculate as to where we're going. A V-shaped recovery is fast down, fast up. And some recessions are like that. They bounce back very fast, and that's great. That's clearly what everyone would love to see. The president's reelection campaign is predicated on that. That assumes that we get a vaccine up and effective and out there this fall. So if you believe that that's going to happen, you believe in a V-shaped. The economy was very strong before COVID. Remember last year, past few years, it's been strong, full employment, rising wages, booming stock market. So it's good foundation. And if you look at the stock market today, you see that despite the very low earnings of the companies, massive layoffs, unprecedented layoffs, and a wave of bankruptcies coming our way, still the stock market is booming away. And so the investors, who are all investing our pension funds for us, by the way, think that we're going to have some kind of a V-shape. All right, so that's the V. What about the L? That's the negative, the pessimistic. The pessimistic version is that this thing grinds on and on for years. And what would be the driver of that? That would be that we essentially don't get a vaccine, and we don't get a really good cocktail of drugs. And so that social distancing is really the only tool in the kit. And so we distance, we let up a little bit like we're doing right now. Then we get a second wave of infections. We tighten back down, things calm down a bit. We lighten up, we get the third wave of infections, and we just cycle through that until we move towards some form of herd immunity, which might be in the 50, 60, 70% having been infected. Rates now are in the single digits, okay, they've been having. Outside of New York and a few places, it's been low, still low, all things considered. So that's a grim, because there's a lot of businesses that are holding on right now, but that they can't hold on for years like this. And so the layoffs, and also the ability of the federal government to just pour money into the economy is not infinite. The way I view it, the image of what's going on in terms of the recovery policy of the government is you've got a patient on the OR, the patient is hemorrhaging blood, and you're transfusing blood. So you're putting it into the patient's arm, it's pouring out of the rest of the patient. It's just going right through. If you didn't pour it in, the patient would be worse off. Okay, what about the U-shape? U-shape obviously is kind of in the middle. I personally am probably a U-shaper in the sense that I think a V-shape, we're just not going to get that kind of a vaccine that fast. I do note that all the senior executives of Moderna, the leading vaccine company, have all sold their stock. I mean, that is not an optimistic sign. But on the other hand, the notion that we're going to be in an L shape and be dragging on this thing here in the United States for 10 years, also a little different. Really, the question is going to be is this is going to accelerate other kinds of deeper transformations that were going on in the economy, particularly automation and artificial intelligence. We see it in telemedicine, but it's everywhere. And that is going to clearly have adverse job implications in the short term, positive ones in the long term. But in the short term, those two together, the social distancing plus just the technological obsolescence of a lot of people's jobs, could be a problem.
So, Jamie, let me pick up on a topic that you just mentioned, which is the federal policy in response to the pandemic. So obviously, I think there was widespread agreement that something needed to be done, and someone needed to prop up the economy during the short term. What are the downstream consequences of the U.S. government spending $2 to $3 trillion that we don't have on this short-term cure? And we understand that without it, it would have been much worse. But when are we going to experience the downstream consequences, and what might those be?
Well, this is all borrowed money, and borrowed money has to get paid back. So that's the main thing. Now, everyone in America loves deficits. We all love deficits. The Republicans just cut taxes a couple of years ago, massive deficits. Everybody loved it. Democrats love to spend money. So it's going to be an interesting thing. I do believe that somehow this is going to have to be repaid by taxes. And there's a couple of bad choices with taxes. There's taxes on individuals, income tax, and that dampens consumer spending. Consumer spending accounts for 70% of GDP. And right now we're giving money to people to go, please spend your money, taxing them. Or you put taxes on business, corporate tax, and then that, of course, encourages them to shift to lower tax parts of the world. So none of these are very attractive, but we do. The real way to do it is to grow. If the economy grows, then it's easier to pay those taxes. And what we really hope is that we don't get high rates of interest. Because what's keeping the whole federal economy going, the budget, is that we have a lot of debt, but we're paying almost no interest on it. And so that's great. It's actually a good time to borrow. But if the interest rates rise, and that we're getting pretty much into speculating about international monetary flows at that point, which we don't need to do.
So let me just pick up on that theme as well. So we have international participants on the call. What is the sort of how has the U.S. economy responded vis-a-vis other economies, Europe, Asia, and what can we learn from those that came before us in terms of the economic response and recovery?
Well, the only one that really came before us in a real effective way is China, and China has been generally a very well-run economy. I mean, if you don't worry about democracy and individual rights, you could get stuff happening. And so they're back to work and they're producing. They're able to use their productivity to offer help to Italy and to lots of countries, and drugs and personal protective equipment and stuff like that, as well as money. So they're and of course, with our president kind of becoming an anti-globalist, China's taking up the position, wants to be the new world leader. That's clear, and we don't. And so they're all happy about that. We're all happy about that, I guess. I think that Europe, the basics of the U.S. economy are strong. It's partly because of technology. We do have our financial system is in pretty good shape. We've got really pulled out of all the recession of 10 years ago. The banks' balance sheets look strong, which is really important in this. And so the basics are good, but if we have the stop start thing that we have to do over the next several years because we don't lack anything better, it's going to be a problem.
And what about, a lot's been written about the government response in Europe, the sort of paycheck protection philosophy versus the U.S. response, and what do you make of that, and how might that impact the recovery?
Well, I think there's different ways of putting money into the system, and America basically believes in the trickle down. Give the money to the rich people and it'll end up trickling down to the poor people, and the Europeans are a little bit more, give it to the working people and it'll percolate up. Whether they're different or not, the big fear for the European economy is not the short-term macroeconomic, let's restart, let's get people back to, so they can go out and get a dinner in a restaurant type stuff. It's okay, once you've gotten there, what's the engine? What's the where's the innovation? Where's the entrepreneurship for the industries of the future? So Brexit has done huge harm to the European economy and will continue to. And the stresses of COVID have torn, at the fabric of Europe. And so I'm a big supporter of Europe because it's, along with North America, it's the strongest place for democracy, individual rights in the world. But I fear a little bit that they will have, even if they have a short-term recovery, what's going to be the longer-term liftoff for Europe?
One last question on this topic, and then we'll shift gears to talk more about the healthcare economy. Which sectors of our economy in the U.S. have been hit the hardest, and which ones have been spared or had the least impact?
Well, clearly the ones hit immediately are the ones which involve face-to-face, and that is the whole hospitality industry, restaurants and all that, and travel, which is a big industry, airlines, hotels, rental car companies, all of that. And then all the services that feed into that, all the downstream, the suppliers. When you think of, let's say, for example, the fishing industry. We're in San Francisco here. I'm in San Francisco here. And we, of course, have a fishing industry. Fishermen are hurting. Why? Because they sell 70% of fish is sold and consumed through restaurants. So they are hurting. They're a downstream supplier. They are now trying to do basically farmers market type stuff, direct to consumers. Consumers are cooking more fish, which is good, but it's no way is it picking up the slack of the restaurant industry. The parts of the industry of the economy that are doing well, of course, are those parts which can be done virtually. This is the whole tech industry, and all of the basically the COVID clearly is affecting the working class much more severely than the professional class because of the ability of people like you and me to keep our jobs, keep working, whereas people who their jobs involved being outside and interacting with people are more adversely affected. Where we need to see bounce back is in construction, very important, and agriculture. We've still got problems getting enough ag labor going out there. So anyway, those are parts of it.
Great. Well, we're going to shift gears to a different topic, but I would ask that any of the participants who have questions on the macroeconomic impact and the recovery, please go ahead and put those in the chat. So I want to shift gears and talk about a different topic, and that's employment and insurance. So first of all, how has the pandemic impacted the percentage of Americans who are insured versus uninsured, and within the insured sector, those who are insured through their employer versus the government?
Well, the first thing is that the employment effect is severe, but it's also highly localized, is variable. Here in the great state of California, nationally, unemployment rate is 15%, highest since the 30s. In California, it's 20%. In Los Angeles, it's 25%. So you just see, and this regional effects. This is going to move around because we know that the infection's moving around now. That it's coming down in some of the places it's with hotspots, and it's bubbling up in mid-sized towns in Georgia, in South Dakota, and places like that. From the point of view, we're moving towards talking about the impact on healthcare. It's really about health insurance. The good news is that in the short term, people losing their jobs are about 2/3 of them are retaining their employment-based coverage. It's partly because the government is subsidizing jobs, and partly because employers can remember how hard it was to attract labor. Only 4 months ago, in January, we had a very tight labor market. And so they are furloughing people, but paying their health insurance, which is great. For those that do lose their health insurance, we have options. Thanks to the Affordable Care Act, we have the health insurance exchanges. They are growing enrollment. And we have better expanded eligibility for Medicaid. Now, obviously, this is regional as well. In the more conservative states, many of them did not expand Medicaid. And so the laid off workers, realistically, to be on Medicaid, you have to be a single mom or disabled, basically. And they also have been fairly hostile to the exchanges, and they haven't been pushing the exchanges, whereas in more liberal states, they have built more of that safety net. So insurance is being much less affected than is employment. Also, by the way, Medicare is not directly affected, and for orthopedics, certain parts of orthopedic surgery is heavily about Medicare patients, and so no change there directly. So I would say in the immediate term, we're lucky. The insurance system is kind of holding together. If we have an L-shaped recovery, you'll see more and more loss of employment-based insurance, and that could lead to a more of a tipping point where the exchanges, instead of being the residual for people who don't get employment-based insurance, is almost like employment-based insurance could be more the residual, and a massive enrollment in these exchanges.
On that point about Medicare, so I've heard that said before. So in prior recessions, as the economic conditions put pressure on entitlement programs like Medicare, like Social Security, and caused debate in Washington around the how to fund those programs, do you not see this $2 to $3 trillion addition to our deficit somehow impacting entitlement programs down the road?
Oh, sure. Oh, yeah. Everything's going to be impacted, and everybody that gets public dollars is impacted by the public budget. I mean, already at the University of California, they're just announcing all kinds of cuts, and so that's definitely. So how's it going to play out for Medicare? Medicare is obviously a very politically popular program, and the way that politics and Medicare work out is that the politicians never want to directly touch the beneficiaries. They don't, because the beneficiaries are the ones that vote. And so if they've got a problem financially, they take a swing at the providers. And that's the first and biggest chunk of providers is the hospital sector. That's number one. Number two comes the pharmaceutical companies. After that come the physicians, and then everybody else. And so the easiest way for them to squeeze those sectors is to simply not increase payments. It's always easier to not increase than it is to decrease. That's very painful in an inflationary time. If we've got no inflation for a while, they weren't going to be increasing those payments anyway. So I don't know, but it's still not the same as what you see if people lose their insurance altogether, or if people, I get to this in the other types of insurance, if they really move to insurance designs with a lot of consumer caution.
So do you see, well, let me ask you then, so that's on the public side. How have the commercial or private payers been faring through this? I think there's a presumption that people were avoiding healthcare, and therefore their spending, their medical loss ratios must have decreased considerably during this time. But how are the publicly held private insurers faring?
They're doing great. They're great. It's just absolutely true. Their premiums were set last year based on certain expectations, and then suddenly people stopped going into the doctor or to the hospital, and they actually, of course, they're paying for COVID care, but outside of New York, there just hasn't been that much of it. So they're doing very well, thank you. They are worried about what's going to happen next year. They're worried about a couple things on the next year. First of all, will there be a big bounce back of people flooding back in the fall and in next year wanting the care that they've deferred? And how much of it is deferred and how much is never? When's it coming back? Now, later, never. They have to predict that. And they're also worried about pricing from the providers, because the providers are hurting very bad right now. As you know, volume is way down. And so the providers, it's very hard to imagine that they're going to come up with any better idea than let's consolidate further. Let's have hospitals employ any remaining non-employed doctors. Let's do a bunch of mergers, and then let's raise prices against the commercial carriers. They can't raise prices against Medicare and Medicaid effectively. So that could happen. So insurers have to try to figure that out.
Do you foresee a decrease in healthcare spending per capita and healthcare spending as a percentage of GDP in the U.S., given that you just mentioned GDP is expected to decline as well?
As a percentage of GDP, healthcare is probably going to rise. There's projections. It's right now. It's been around 17.5%, somewhere in that of GDP. Fluctuates a little bit. Some projections that go up to around 21%, mainly because of the denominator. In terms of the numerator or spending per capita, I think it's going to go down. That's if you think about what's happened over the past decade. 10 years ago, we had the big recession, and what happened from healthcare, health insurance? Well, in that next 10 years, there was this huge shift of benefit, enrollment into high deductible health plans that really surged during that period. Employers, they're not that creative. They thought, gee whiz, I've got a deductible at $250. Why don't I just raise it to $1,000? Oh, why don't I raise it to $3,000? I mean, that's kind of like the level that they're talking about. And so that's what they did. And then consumers look at that and they don't feel all empowered and skin in the game. They just feel like, because most Americans don't have $500 in their savings account. So they use less care. And so we've had a relatively slow growth in the volume of care per capita over the past decade. We have seen increases in prices because the providers have been smart and they've consolidated and they monopoly power and all that. So we could see more of that. We could see more of that. We use people who have what we call thin insurance. They can decide that they're not going to pay their deductible. And that does hit orthopedics because you've got a lot of procedures that will drive the patient right to their deductible before they get to the elevator. Okay. And so you're going to have a whole lot of people saying to themselves, yeah, my knee really hurts, but is this where I want to put $3,000 of my deductible right now? And ditto for spine, especially for spine. So that is going to, I feel if I was trying to figure out, prognosticate orthopedic volumes, I would be looking at that.
So you'd be predicting a decrease in demand because of the out of pocket responsibility of the insured.
Yeah, I mean, there's going to be a bounce back. There's a lot of deferred care that is going to bounce back. So when patients feel it's safe to come in and doctors feel it's safe to operate again on schedulable cases, non-emergency schedulable cases, that's going to come back. But the trend line is and I'm speculating, but this just can't be good. This cannot be good for volumes.
Yeah, and so let me just ask one final question on that, and then I'll ask Stefano if we need to leave some time for questions. But so again, back to employers. So a lot of the shift in pressure from both the government payers and the employers towards value, where orthopedic surgery has really been at the forefront and been really first movers in that space, both in terms of the delivery model and the payment model. A lot of that pressure came from the perception that healthcare spending per capita was too high, and employers were feeling pressure that they were spending too much on healthcare, and it was an easy place to cut. So you've told us that you think healthcare spending per capita is going to be going down, so maybe less of a spotlight on that in the short term. But you've also told us that employers are really hurting and really struggling. Do you think that increases or decreases pressure on healthcare and transitions to alternative payment models and other systems for delivering care?
I think that the pressure is going to continue because the government, Medicare, and the government, the private employers and insurers, they're all feeling stressed. I mean, the private insurers have a short-term boost, but basically they're going to be stressed. And so they're going to be looking for things that moderate the trend. I think that it's incumbent on the profession, and I appreciate you're a leader in this, and there's others in orthopedic surgery that are leaders in this, to say to the profession, listen, we have to change our way of doing things, and we've got to be able to come to the buyer and say, listen, I don't deliver my little procedure. I'm part of a group that delivers musculoskeletal care, and I'm willing to stand by that. I'll measure quality, you can measure quality, whatever, and we're going to have some sort of bundle payment, and we will be accountable for the cost of that. And because when you think about the let's go back to, you and I have worked a lot on reference pricing. Reference pricing came right out of the recession 10 years ago. State of California, basically bankrupt, turned around to the state employees program and said, spend less. State program turned to the consultants. The consultants said, high deductible. The labor union said, no. Okay, so they said, what else can we do? And so they said, let's look at our data, and they found this incredible variability in the prices charged by hospitals for orthopedic surgical procedures. And so they said, okay, we're going to set this thing up so that the patients that pick the places charging less than $30,000, it's going to be a generous, and if they pay a place that charges more than $30,000, they'll pay the entire difference between 30,000 and whatever that number is. And gee whiz, patients, once they started spending their own money, they moved. And the doctors did too. This didn't apply to doctors because the doctors were all charging just the fee schedule. They weren't getting any of this big money out of the hospitals. So it really worked. But it's very limited because that was just for the procedure. What the buyers really wants to say, we want to do that, but we want to do it across what Michael Porter at Harvard, who you work with, calls these integrated practice units. Really, call it surgical units that include the procedure, the pre-op, the post-op, physical therapy. And of course, in the current era, we're all going to, a lot of that and stuff is going to be virtual because you can do a lot of good things with e-visits and other things for the pre-op and the post-op monitoring. So I think it's an opportunity, and I think that, but it is going to have to be something that saves money. It's quality, improving quality is what gets the doctors engaged. Saving money is what gets the buyers engaged.
And on that note, and we're going to shift back to Steph here in a second, is, I think, so what you're telling us is this does create an opportunity for innovation from our profession, as we've been doing all along since that last recession. And we've really been leaders through our co-sponsor of this conference, the AAOS, in making the transition to value. And so it sounds like your belief is that we may have even additional opportunities for innovation coming out of this pandemic.
Yeah,
so,
and I just let me say something just on that. Everyone's talking about, okay, one of the big deals about the epidemic is it's going to really be a tipping point for virtual care, telemedicine, which it is. But telemedicine which is great, is only a bit of what the real expense of healthcare and the real quality. And so you guys are aware of frankly the dollars flow. And so putting that together, having virtual be part of it, but using this as a tipping point, I hope that the COVID epidemic will be a tipping point for value-based orthopedics, value-based musculoskeletal care generally, but it's up to the profession to do it. And like I say, you do it or it shall be done to you.
Yeah, Jamie famously said to me one time, healthcare reform will either happen by doctors or to doctors. And so it sounds like there's an opportunity for it to happen by doctors. So I'm going to turn it back over to Steph, and he'll, I'm sure, get to some questions. And I have some additional questions if there's time, but I'd like to hear from others.
Yeah, absolutely. Thank you very much, you guys. We could have gone on forever, but thanks for giving some. We do have 7 questions. I'll just ask them as they're written, and there's a little bit of repetition from what you've already said. So the first one from Dr. Cummins: how do you think COVID-19 will affect medical research funding? I think you've sort of alluded to the impact of debt on healthcare spending by government. When you want to address that?
Well, what I hear in the world of the funding agencies I do is if you don't have the word COVID-19 in the title of your research proposal, you are not going to get funded. So if you're researching COVID, you're good. If you're researching anything else, we're starting the lean years.
That's been our experience as well in both health services research as well as translational research, that all of the funding, not most of it, all of it is being diverted to COVID-related research.
Fascinating. From Richard Capper, what is the long-term situation between insurers and hospitals, and what will change? I think you hinted at it, but let's just go straight to the heart of the matter. Do you think there'll be a change in the way insurers and hospitals partner in the delivery of healthcare?
Well, I would like to think so, and I know that the best provider system, I think, in this current situation is the Kaiser Permanente. I've been doing a paper with Kaiser on their experience, and because the Kaiser Health Plan stands with the Kaiser hospitals and the Permanente doctors. They're not cutting them off. So they are able to do all this re-engineering of care, and and that's what they have to. They've got stresses too. They have to worry about membership losing their insurance, and they've got issues to do. But I found it really unfortunate that when, like, for example, United Healthcare, they're about to break the law, violating the medical loss ratio of the Affordable Care Act because no patients were getting care. So they were in violation of the MLR. Boom. What did they do? The principle of the MLR is the money needs to go to the doctors and the hospitals, but they didn't give any money to doctors and hospitals. They gave it to employers in the future pay down of their premium. So that gets them business going forward. Nothing wrong with that. But I mean, it didn't help the doctors in the hospitals who are bleeding right now because they're empty. They're empty. That's the problem. So we really want the hospitals, I mean, the insurers should take, and I don't know how to do this in the environment that we're at, some accountability for their network core. They should have their best providers, ideally the ones that were integrated, as we were talking earlier, into these integrated practice units, and we're taking accountability for quality and cost. Keep them whole.
So along the same lines, because the insurers having significant amount of, they're sitting on a lot of cash, and you did guys both talked about one reason why they're probably want to keep that cash because they're concerned about that care coming back down the road. But the question from Nico here is, do you think payers will take that money to vertically integrate care and acquire distressed care delivery assets? You see that this financial structure will cause a shift of insurers going into the delivery side?
I think that there's some of that just going on anyway. Most obviously, United Health Group, through its Optum Care division, has several thousand physicians who are full-time employed members of groups that are owned by Optum Care. I mean, there's all these legal things, so they're not actually working for Optum Care. There's corporate practice and all this kind of stuff, but they're very aligned with that, and it is working, to my knowledge, quite well. It's a very big deal here in California, in Southern California. Some of the most famous medical groups are now affiliated with Optum. And you see some elements of that. You see up here, Blue Shield, Anthem, making investments. I think a lot of it is actually a fear of hospital consolidation. Is really what's going on, and they would like to keep alive physician entities which are not hospital centric, so that they can do the things like favor ambulatory surgery over a hospital-based outpatient. You know, the usual kinds of things.
Thank you. One more question. You may have sort of answered, but it's come up, so let me just bring it back. And the probability of inflation impacting Medicare costs. This is how it's phrased as costs as opposed to premiums, but you probably think of it both ways.
Yeah, well, first of all, we don't know whether we've been waiting for inflation for several years now. I mean, it's just unbelievable. This is like interest rates are, they range between 0 and negative. It's really unbelievable. It's amazing, historic. If those interest rates go up, the federal government is in very bad shape, because it then has to divert money from Medicare, from the military, et cetera, to debt finance, debt servicing. And so we certainly hope that we somehow collectively pay down a bunch of our debt before the interest rates go up.
With that hopeful thought.
Yeah, that's right. That's right.
We're getting into the last 60 seconds. Kevin, you said you had a couple of questions you wanted to ask. I'm going to give you the last one.
No, I'll just say that, I think this has been a great session. I think that what we've heard is that a lot of these entities are really interrelated and intertwined. And so whatever we see that healthcare was likely to be a bellwether for the rest of the economy. I'm really proud and excited that orthopedic surgery with Stefano's leadership and the AAOS is really trying to be proactive about driving forward with solutions, and I'm really encouraged and optimistic that we will come out of this better than we were before. And so, thanks again for including us, and thanks for all the questions that came from the audience. And look forward to the rest of the conference.
Thank you, sir. Thank you both. Thank you, Jamie. Thank you, Kevin.
Thank you.
And we will move on to the next session, and we'll have a usual 5-minute break, and look forward to seeing you there. Thank you so much, everyone.
So, welcome to our next session, the Digital Health Policy Response as part of DOCSF and the COVID-19 Orthopaedic Recovery. Very specifically, we're going to spend some time in conversation with Kevin Schulman. Kevin, so where are we reaching you today? Where's home?
I'm in right outside of Stanford in Menlo Park, California. So beautiful, sunny Northern California.
Well, it's so good to have you here. So, Kevin, you are best known as being clinician, physician. So you've got a dual appointment. So I'm a nurse economist. You are the physician economist. So you've got an appointment in Stanford as a professor of medicine, as well as over in the business school. And your work really has been focused on digital health innovation and thinking about policy and the health economics of that. How do you characterize your work?
Yeah, I think that's great. I mean, how do we improve the value of healthcare for patients? How do we understand the cost of healthcare? And how do we think about innovation as a way of transforming the economics of what we see right now?
Yeah, so we've invited you here really to help us think about the digital health policy response and doing that in light of COVID-19 And you had a recent article that came out in the New England Journal of Medicine. And your title of that is COVID-19, Healthcare's Digital Response. And I love the way you opened it, in which you talk about that truly this pandemic is a result of our technological innovation. Why don't you go ahead and tell us a little bit more about this article and what prompted you to write it, and thinking about our healthcare response in the time of, or digital healthcare response in the time of COVID?
Yeah, so thanks. I mean, if you think about pandemics of the past, the Spanish galleons that were outside of Venice that had to be quarantined for 40 days offshore, spread of infection was really slow. In an incredibly short period of time, the entire globe now has been exposed to COVID-19. And it's because we're in such a digital and interconnected world that's occurred. And the contrast there is between this incredibly fast digital world and our, what we call in the article, our analog approach to medicine, which is very much bricks and mortar based. And what we've seen is this amazing capacity that we've had to move very quickly from bricks and mortar to virtual visits. At Stanford, we went at the height of our COVID response to about 70% of our clinical visits being remote. I was talking to a friend of mine last night who's an urgent care physician. Half the visits that he does with patients now, they never need to come in and be seen. And so here's the potential that we've been talking about for a very long time of being demonstrated in front of us. And all of us migrated very quickly to this new way of taking care of patients.
Yeah, well, that's one of the things that you mentioned in the article, is that we have built a system of care, model of care, a payment, the financing, how we finance our care, in a way that actually is more to do with transmitting the virus. I mean, when you think about busy waiting rooms, emergency departments, these are all of the things that just cannot happen during an outbreak of a virus that we don't have a therapeutic and we don't have a vaccine for. So that is quite interesting to think that our system of caring really is contributing to, and really would increase the spread.
Well, we had this, obviously in SARS, we had entire hospitals were contaminated and had to be shut down. We have this issue about the healthcare workforce and protecting the healthcare workforce. And then we have the issue about PPE shortages. So, if a patient's coming in with symptoms, do I have enough material, to keep myself and my office safe? And so this idea of remote visits really made a lot of sense. When I round in hospital medicine for the COVID positive patients, we spend our time talking to them through FaceTime and Zoom Hangouts, or Zoom chats. It's so the technology's all been there. We've just not thought about using it in the way we've decided to use it over the last couple months. And obviously, we wrote that article before all this even happened.
Yeah, can you say more about the experience at Stanford, going from what was your rate of using digital technologies or virtual visits, virtual care?
It's this is the Bay Area. Traffic is horrendous. Patients would come 2 hours for their follow-up visits, and then within a month, we went to all of those now are remote Zoom visits. If patients need ancillary services like labs, we can arrange those. And so very quickly, we just changed the experience of care for people. But that meant people weren't coming in, that people weren't coming in the clinic, they weren't being exposed, the clinical staff weren't being exposed, the people behind the desk were not exposed, the people behind the desk were not congregating, they were keeping social distancing. The last time I was rounding, we were thinking about the elevators. And we had two medical teams that were approaching the elevator at the same time, and I had to suggest to everybody we had to take separate elevators. So it's very hard to social distance in the environments that we've created.
Well, the other part too is how you are in an elevator actually. So are you guys practicing that, where you limit the number of people in an elevator to the sides of the wall that people can pay attention to?
We've gotten, when I first was rounding in March, when the epidemic was first starting here, no one was wearing masks. We were trying to figure out how do we screen people coming in. Obviously, visitors are not allowed. The last time I was rounding, everyone was wearing masks. We get checked into the hospital. We have to do a symptom check every single day. And I think we've learned a lot in a very short period of time about how to protect ourselves. The latest data I heard was actually amongst our residents, Stanford started to do serology testing. We only had one resident that turned out to be COVID positive, and that person had been traveling abroad before during rotation. So most likely that didn't happen here, thank goodness.
And I hope your colleague is well and
they're doing well.
recovered.
Yeah.
Good.
Yeah.
Good to know. Good to know. So when we think about do you want to say more about the article that you wrote? I mean, some of the points that you were making in here.
Yeah. So there are a couple of things about digital. So one is, we went to telemedicine, which is still the same kind of visit that we were having. We were just doing that really. So that was a great benefit to patients. But to really go digital, there are a huge number of capabilities and ideas that you could use and deploy that would help people. I'm very involved right now with some computer vision work. So for orthopedic surgeons, imagine the 3-month or 6-month visit was actually the computer vision assessing whether or not the gait has returned to whatever the expectations were, and with very precise levels of measurement. As you think about all the different digital technologies that surround us each day, how would we use them in new and different ways to take care of patients? We're just at the beginning of all this. So even, so specifically what happened around the time we published our article, Medicare did 2 things. One is they decided to pay for virtual visits the same way they pay at the same rate that they pay for in-person visits. So that was a huge benefit to us to move the migration. But the other was that they migrated, they used their enforcement discretion to say they weren't going to enforce HIPAA during this crisis. And so we could do things like Zoom and FaceTime that may not have been HIPAA compliant, we would not have been able to do several months ago. Stanford's solution that we stood up actually was HIPAA compliant, which is kind of interesting.
So,
but a lot of that, a lot of the payment models are still in-person models. It's not building a chat bot to take care of your post-op patients. It's not using machine learning algorithms to try and predict who's going to be the highest risk patient coming in or how to do the best job in follow-up. And so the payment models are really to support more use of people rather than think about how can we use the technology to really drive efficiency and creativity in the process.
And when you're talking about the policies, oftentimes when we use the word policy, there is a tendency to have the mindset we're thinking at the federal level or the national level at a very high, where there's laws and guidelines and compliance and regulations. There's a lot to be said about institutional policies or practice policies or professional disciplines. I think that's one of the areas that oftentimes gets overlooked. Actually, at this moment in time, we have an interesting sandbox to innovate in. And we've never seen as much freedom as we've had. What do we need to think about as far as practice and institutional policies that help us the technologies have made these things possible. The policy is what's creating what's permissible. You've had some very direct experience with Stanford, but what about some of these policies that we need to think about so that we can what does our policy response need to be so we can further these gains?
Well, I think that's a great question. So a couple of things we talked about in the article. One, it's remarkable. We've been debating these issues. I went back and found a telemedicine paper I wrote 20 some odd years ago, about virtual care for dialysis patients. So we've been debating this for forever. And then all of a sudden in 2 months, we've changed the way our entire perspective on this. So there'll be a lot of pressure to go back. Nobody likes the new thing. Everyone wants to go back to the routines that they were comfortable with. And obviously the situation that we're in is not going to resolve anytime soon. So our ability to go back the way it was is not that great. Plus patients now have this new experience of care, and whether they're going to want to go back to driving 2 hours again to get their 15-minute visit is an interesting question. So the first thing we talked about was really how do we evaluate what we did? So when the debate comes and say, when people start talking about the quality of telemedicine visits or whether fraud has occurred, we'll have some really good data on that. The second issue is, in terms of the institutional policy, so obviously we're constantly getting advice, very conservative legal advice around things like HIPAA and application of HIPAA to these types of technologies. One of the things we talked about in the paper is actually, how do we make this permanent, this idea of, innovation, rather than waiting for permission and going through some regulatory process, how do we make it permissible ex ante? And so we even talked about the way of creating a safe harbor. If I want to try something and the regulatory guidance is not very clear, using some texting application or WhatsApp or things that people are using, I could write a letter to the Office of Civil Rights at the HHS. They could, and then in fact, once I write that letter, then I'm covered for some period of time until they can make a determination about whether or not we're in violation of the policy. And so that would be a way for us to actually move all of this forward, get some real evidence to support whether the risk-benefit trade-off, and at the same time address some of the regulatory concerns. To the state level policy issues, we're dealing with both privacy policies at the state level and licensure issues at the state level. So we regulate medicine the way we did when we wrote the Constitution in 1787. Medicines, in 1787, you walk to the doctor. And so it was intrastate and not interstate commerce. And the kind of technologies we're talking about today know no boundaries. I mean, lots of us are involved with talking to patients in other states, talking to patients in other countries. Lots of our health systems are loving the idea that they can do virtual consults around the world. And yet we're regulated at the state level as if, again, we're still practicing the old way. So that's another area to look at for change.
Yeah. So from the standpoint of the data piece of this, that's a question that people keep coming up because the data privacy laws, they change. First of all, they are changing. And as we think about how we're going to break the transmissions chains, so much of what we need to be looking at is people's data. We need to know who they've been, where they've been around, so that we start doing contact tracing. What are you seeing as far as models, or not models, policies that are going to help us to keep the transmission rate low, interrupt those cycles, and at the same time maintain people's civil rights, their civil liberties, their privacy, and sensitivity?
Yeah, I mean, I think this is really challenging. We've Google stood up and a really interesting idea about looking at mobility based on cell phone data. I've done some work with them. They built a map for me of access to healthcare anywhere in the world. So the capabilities they have are really amazing. I think there's two issues. One is individual contact tracing and private opt-in and opt-out. But the other issue is aggregate data. So I think one of the things that's really interesting is, and Kate Baker at Chicago has shown some of these data, irrespective of whether or not I know where you are as an individual, can I know what the pattern of social interaction is in your community? And that would help me say, well, you know what, Menlo Park is being safe. So even if Santa Clara, if our county has an issue, the people in this community, don't need to have the same rules as people in another community. And I think it'll be really interesting to see if we can get to that level of granularity on some of these tools. The other piece this is bringing up, in terms of opt-in, opt-out, and this is a broader issue for digital, is who is this solution architected around? And right now, if you think about our electronic health record systems like Epic or Cerner, they're really architected around the provider. The idea that you're potentially infecting your social network, my electronic health record at Stanford doesn't help me with that question. Really, what I want to know is more about you as an individual. But that actually brings up a broader issue about your own access to your health data. If you came to Stanford for one service, and you told me you moved to, you were out here and then you were in Austin. Well, what happened if you got a visit here and a visit in Austin? How does how do people find out about that? For orthopedic surgery, you know, I was talking with Bill Garrett at Duke a long time ago, and he was talking about revisions, and I said, you know, he was nice enough to give me a repair, and I have a screw in my knee. I had no idea I had it or where it came from. But I said, you know, this makes no sense. Why don't we register these things? Why don't I have, as a patient, have a record of these things? And that's now migrated to this idea of personal health records, where you take all your data with you as you move forward. So when you have to you're in a new city and you need a revision, you're not stripping the screws in the OR, but you know actually what kind of equipment the patient received the last time they saw somebody. And so I think as we generalize more and more, we're going to see besides the fact that we could do digital, we might want to migrate to architectures for data that make a lot more sense.
I was going to say, it's been really interesting spending time with the epidemiology community, because so much of trying to plan our resources, plan who's safe to open and when, is based on data that doesn't exist in our medical record. It's actually not even health data, it's behavior data. And it's an aggregate. I mean, and it's been very interesting to look at how we've been working with major employers and retail environments, and to take a look at how many people actually came into work, how many people were riding the bus, what's the CO2 emission. So we're using data that exists outside of our health record to really help us understand where do we think those likely spots are that will be safe, and we can open up safely, and those spots that are at greater risk. So, and again, it goes back to this individual data, aggregate data, and should you be able to know all of the places that I've been to and who I've been around?
Yeah, you know, but I think we can generalize a little bit more. Nick Christakis a while ago did some work off the Framingham data set and looked at smoking cessation and obesity. And both of those actually were group activities. So people and their friends quit smoking together. People and their friends changed their dietary habit together. And in healthcare, we don't see that. We see one person at a time. And so it may be, and we give the same advice to everybody. Well, and we have this amazing obesity epidemic. Imagine instead if I had data on your community, your network, your individual social network, you know, the Facebook view of the world to a health record, you know, I would think about how to influence your health and your behaviors entirely differently. You know, and I could give you much more tailored and nuanced recommendations, and maybe we could get compliance up from wherever we're at, 50, 60% up to much higher. So I think we're just at the beginning, but I think all of these ideas that we're drawing on right now give us a glimpse to wait a second, maybe the data we're collecting and the architecture we've developed for the data collection are not the ones that we need to move forward.
So in thinking very specifically about orthopedic care and policies around digital health, digital tools, we've had a very short period of time to be working with these. We don't have a whole lot of experience yet. What we have has been quite interesting. We've had more volume than we've had time to take a look at what we're learning, what we're seeing. Can you, just based on this small time frame, the small experience, what are some of the gains that we need to protect, from the standpoint of being able to deliver better, safer, more value-based care, or valuable care is probably a better way to put it.
Yeah, I mean, I think we go back to I would say, to start with, what are the services we're providing, and how do we describe them as this combination of in-person and virtual? And so even, what's a visit, what's the 90-day around a surgery, how do we think about that? How do we describe that and chart that and bill for that in ways that are agnostic to the technology that we're using to do those things? So
we just refer to it as a visit or an encounter.
Yeah, I mean, it's at some level, Kaiser as a capitated system has been doing a lot of this virtual for a lot longer than the rest of us. But a lot of things that we do are predicated on site of care. If I do a 90-day bundle and I have to do a patient-reported outcome assessment, there's ways we're doing that. That's again nurse administered or physician administered or in-person administered, and can we move those things digitally? But then I think we can come up with the next horizon is what's, given that, if I put you in a room with our creative MBA students here at Stanford or our technology students, what is the vision that you'd want to do for your practice? How can I do digital assessments or remote physical exams? Can I send a patient a video and have the computer look at how they do some activity and give me a report back? Do I need to see this person or not? Obviously we spend a lot of time in our office screening out people rather than screening in. The idea of practicing at the top of your license, imagine you saw 20 people a week, all of whom needed your service, rather than 100 people a week, 80 of which don't need your service, didn't need to come in, and you're wondering why they got referred to you. So, can we build new types of screening tools to help us, make the patients' lives better, or make our time more efficient, and hopefully have a greater impact on the patients that we see.
So, so those are some of the policies, and they really are very much from the site specific. So we become agnostic to that. We become agnostic to the delivery or the medium in which we're interacting, and we're more focused on are we addressing the problem, and are we doing it in a way that's safe? I think the other part too that we want to be is good stewards of our resources. Are we doing it as efficiently as possible? Hopefully in the realm that we can actually serve more, because we've talked about this multiple times. There is a shortage of practitioners. Every single, whether it's the number of surgeons we have, the number of nurses. So are there ways, when you're thinking about using the talent pool that we have, this has been some of the real challenges that we've heard about, is the burden on documentation. What do we need to do in this policy response? Because a lot of those documentation rules were relaxed, or I think in many cases they were just ignored because you couldn't really meet them in the situation of having to wear all this PPE. So there was a lot of regulation that we weren't following, and they weren't enforcing all of that. What can we do with our policy response to address, in this digital age, removing some of the frustration? Because that's what we hear so much, is the medical record and using it creates enormous amounts of stress and burnout. So we have this moment. How do we capitalize on this?
Yeah, that goes beyond the article that we wrote, but absolutely.
I know. I'm
no, that's perfectly fine.
Taking advantage of the fact that we got you here.
Anyone who's had to enter a record in one of these systems has a very strong opinion about it. We designed. I'll pick on Epic. My friends at Epic. Epic is a billing system. The billing system was designed to meet the requirements of what was a paper system that was mostly designed so that I could audit it very efficiently. You had to do this Chinese menu of services. If you this level, you basically have to say you did this, that, and the other thing, because if I sent an accountant in, they could audit that very easily. And so that's the basic foundation of all of these things. This idea of how do I hold you, how can I audit what you're doing, so that, and then build a billing system so that I can withstand an audit and meet all those requirements. And it was never designed to make the experience better for me and my patient. That was not the requirement. And so, when you think about the next generation, again, in this digital world, if you had a patient with a personal health record and you submit it, why do we have to submit bills? What level of granularity do we need to get to with submitting bills? And we've actually documented some of this for a primary care visit. We actually calculated and reported in JAMA. It costs us $20.49 to submit a bill for primary care. It's much more for orthopedic surgeons. And at an annual level for a primary care doc, we're spending $100,000 a year submitting bills. And the question is why? What are we getting out of that? And as we go to this new world, can we use visual documentation? Can we take pictures of things and have that be representations? Laying hands on a patient is great unless you're in COVID. But the truth of the matter is, a lot of stuff that we do, when I see patients in the hospital now, they've already had thousands of dollars worth of imaging. They already had their echo before they come up to the floor. Me listening for a murmur after the echo doesn't add a lot of value. So, again, we're doing a lot of things because we always did them, or because of the way the payment mechanisms were set up. But it's really time to rethink all of those issues. All of us could say we've had enough. Let's think of a much simpler way of doing this, and get back to spending our time, interacting with patients, but using the tools to do a lot of the low value add. I saw one practice in Chicago where the patient fills out a questionnaire, and when they fill out the questionnaire, it actually auto-populates the electronic health record. You don't get the questionnaire as a doctor, and the doctor has to transcribe it. So lots of different ways we can think about using technology to make our lives much simpler, much better.
So in this digital health policy response, this is a moment for, I think, particularly at the institutional level and then also at the regulatory level, for us to speak very loudly and make sure that we're not putting in hurdles or compliance or checklist items that just really are not suited to a digital world, and make sure that we look at this and say, this would have made sense in an analog world when you didn't have those technologies that are available to you. Some of it's safety, some of it's to make sure that we're doing appropriate care, and that actually the care that we say we did. So there are many things, but it sounds, what I'm hearing is that you're saying we really need to go back and reevaluate the policies that exist, and make sure that in this moment, that part of our response to this is, let's make sure that we don't keep taking legacy things that fit to an analog world into a new digital reality.
Yeah, I think that you've summed that up really nicely. I mean, we've used digital tools to recreate our analog processes. Yeah. And instead of rethinking how would you do these things in a digital way, and how do we really make the most of the technology that's available to us? Because somehow our phones are much more facile at doing the kind of activities that we want to do than this incredibly expensive and elaborate technology that surrounds us.
Yeah. But so we've talked, when we talk a lot about policies and regulation, we think about them from the standpoint of operational. But you've made a very strong point that one of the keys to this response is we got a lot of trust to rebuild. You've got a slide that you shared, again, The Economist. Let's go take a look at. We just heard a presentation by two folks talking about the overall healthcare economy, looking at it at a global level. Can we go ahead and get that slide brought up to take a look at? So on Thursdays each week, the unemployment data comes out, and I'm not sure if we've got that slide yet, but let's just go ahead and give the numbers. So in the space of 8 weeks, we are at how many? It's last I think I saw 40 million people.
40 million people have lost their jobs, and so what we need to think about, and maybe Jamie covered some of this, but obviously a big bulk of payment models in the United States are related to employment-based health insurance, and so there were about 200 million people, which are workers and their dependents, that are covered through employment-based health insurance. So if 40 million people lost their jobs, it's likely that more than 40 million people have now lost their health insurance. So that's an enormous impact that we're going to be seeing right now. A lot of people, even as they open up, are saying, well, there's a challenge. We don't have demand. The patients aren't queuing up the way they were, a couple of months ago. And I think there's several reasons for that. So the first, you talked a little bit about rebuilding trust. So we've now scared the American public that healthcare is an incredibly dangerous place for people to go. Look at the pictures on the news of how sick people are, and how the healthcare workers are getting infected, why would I ever want to get exposed to that? And so we need to start with this idea about rebuilding trust. And in fact, we're going to create a safe experience for patients when they come in. My wife was remarking the last time we went to the supermarket how clean it was. It had never been that clean in all the years we've been going. And they've been working for the last 2 months to think about how do I create an experience for customers that will make them want to come back. And so in healthcare, we got to do the same thing. Do we have?
And I was just say I want to take us back onto the screen, but before we go, I just want to highlight from the standpoint of this graph is stunning. I mean, it's from the standpoint that's over 15 years, and in this very short period of time where people had some sense of familiarity, security, for this many people, that just went away. And so I hadn't seen it just came out yesterday, so I hadn't seen it. And I was catching my breath once again from the standpoint. But it brings up from the standpoint of when we think about those policies, you've got a group of people who were in care pathways. They were being seen. Now they actually, what are the policies looking like? What's this digital health policy response when for many people, their care was interrupted because they no longer have coverage?
Well, I think that's a local institutional response. What are we going to do about this? What are we going to do about part of this trust is, you're my patient. How do I, come in and see me? I'm not going to bankrupt you. This was, people were afraid of the cost of medical care even when they had insurance. And so now, are people going to come in? Is this really a priority when they're struggling to pay for rent? I think that's one set of issues. The other set of issues is, even here at Stanford, people are having to take time off from work. And so, not only did 40 million people lose their jobs so far, lots of other people have had economic impacts, and we're going to continue to see repercussions of this. And so people with high deductible health plans or people, even with the regular deductible to see an orthopedic surgeon, it might be $50, $7,500 plus whatever the ancillary test, the payments are for the ancillary tests. Are people going to have that amount of money in their pockets? And so how do we think about our collection policies? How do we think about copays and deductibles? I think those are all things that are going to be huge barriers right now between now and when the economy settles out.
Yeah, and what we didn't mention, but I think is really stunning, is that with this reduction, the number of unemployed, a huge number of those are actually in healthcare. The number of nurses, physicians who have they've been furloughed, their positions have been terminated. We have a lot of people in the healthcare space, despite having this shortage of a healthcare workforce. Many of those numbers, and do you recall? I'm thinking it was 4 million, or what percentage of the unemployment right now is from the healthcare sector?
I don't know off the top, but as you think about it, I just saw some data recently from California, and it was a couple of percentage of the workforce. What we've seen, and it's been written about a lot in the newspapers. So we kind of have two things going concurrently. One is we're taking care of the immediate needs of the COVID population, but the reduction in demand from the state mandating that we stop elective surgeries meant that a lot of the high-paying specialties, like orthopedic surgery, have seen tremendous reductions in volume, and so that has had repercussions in terms of staff. But the newspapers are starting to ask questions. Why is it that that the healthcare business model was so predicated on these elective surgeries for commercially insured patients, and why is it that we're so vulnerable to this crisis at this point? So I think that'll be really interesting as we move forward. Again, when will that demand come back to where it was is a real open question. If that 40 million people moves into Medicaid, 50, that could be 25% of the commercial market moving into Medicaid, if, assuming they're eligible or we expand the Medicaid roles. But I think that's going to have a big hangover effect on the practice of medicine, the economics of medicine for some period of time.
Yeah. Well, it has, I say, and again, going with the digital health policy, I've seen many where a lot of the healthcare plans have made any of your first visits, they will be virtual visits. So they're using the digital or the virtual experience as one way to, I guess, deliver more care at a lower cost point. So there's, what have you seen as far as at the federal level and the payer level, as far as policies that they're putting in place that are going to impact our business models? And I'm curious, are you seeing where some of these policies are helping us to more readily embrace digital, or are we seeing people push back away from it?
I think we're seeing, I think we're seeing both at the same time. This is the digital, it's like the digital is, we need things like One Medical that just went public right before COVID, closed our offices and just moved entirely virtual, during the peak of all of this. But again, a lot of us grew up in a certain business model. Our practice is based on that. We bought equipment based on that. We rented space based on that.
Real estate, yeah.
Yeah, and so, unraveling that is really going to be an issue. There's just a headline in New York: commercial tenants aren't paying rent for retail spaces. When are we going to decide that we need to do something differently? A lot of us are working in places that just built new buildings or new resources or new outpatient care centers. The people that, own the mortgages on those really want to, have patients back to pay for that. And so, there would be significant adjustments that need to be made. Should we say, reduce the volume of in-person visits to the level that we see right now? That would require enormous restructuring.
Yeah, and so much of orthopedic care is in a surgery center or in a hospital, and those places are also seeing financial difficulties. So I think what most of the folks in the audience, they're looking to us to help them. What would you recommend that they start thinking about, what should they be doing today and in the coming weeks? And particularly as far as policies are being evaluated and written, what would your recommendation be, your prescription on how we need to respond to this whole, we've got a plethora of policies that we're looking at. What should the orthopedic community be advocating for and against?
Yeah, so as a researcher, the first thing you're going to advocate for is research. We really need to evaluate what happened. How do we, did this work or not work? Did patients get better or not? Do they like this virtual versus in person? How hard was it for us to transition to even just giving patients an option? So I think that's the first thing, and we need to, that's going to be really helpful data. The second thing is, a lot of us have been talking about innovation for a long period of time. We're talking about frustration with some of the aspects of practice today. We're talking about the administrative burden. This is really an amazing time to say, well, the constraints are off. What are you going to do? And what would we like the world to look like? It's much easier to take home more pay if you have less people working in your office. There's just no question about that. Especially patients that are not doing, people not doing patient-facing tasks. And so what would it take for us to get to a different vision of how we could practice, medicine using all these tools or using new kinds of services rather than the very people-intensive way we've organized care. I would say, I imagine the people listening are going to break into two groups. One who's going to entirely embrace the digital realm and say, boy, I could do this much, or I could do even more, and develop really interesting, elegant solutions. And then there'll be people that are, have been practicing for 20 years in a certain environment, made lots of financial commitments, really like their practice and the staff they built and the team they built, and this is going to be a very hard era for them. I would say, a lot of people think a couple of kind of broader themes. For years I've been saying, transformation is not linear in markets and is not going to be linear in healthcare. And I didn't know what it was going to be that was going to be nonlinear, but COVID is.
You weren't thinking exponential. I certainly wasn't.
So, but that was a nonlinear change. And then, there's a lot of hope that this is going to be an incredibly steep V-shape recovery, U-shape, whatever we want to call it. There are a lot of things that could lead to really, really severe tails. People don't pay rent and landlords don't pay their mortgages. The people who hold the mortgage pools, are not getting their money. There are reverberations throughout the economy that are really structural and will take a long time to unwind. And so, while all of us would want to go back as quickly as possible to January or December, if in fact this is going to be our reality for some period of time, even after a vaccine's not going to send those 40 million people back to work immediately. We need to be thinking the next year or two are going to look very different for all of us, and it's a time to really be creative and build something new and exciting. There will always be a need for medicine. There will always be a need for healthcare. There will always be a need for orthopedic surgeons. I know I always need them, and what they provide to the healthcare community. But it's a really interesting time for us to rethink what that is and how we're going to do it.
Yeah, and it's a good time to be washing our hands. So. Thank you so much for spending time thinking about what our digital health policy response needs to be. And I feel optimistic. Thank you for giving us some guidance on what we need to be doing. And with that, I'm going to say goodbye and see you again soon. Thank you so much.
Thank you. You've been great.
Appreciate it. Bye-bye.
Welcome back. Welcome to session 8 of the COVID-19, the Orthopaedic Recovery Symposia, powered by the Digital Orthopedics Conference San Francisco in partnership with the American Academy of Orthopedic Surgery and the UCSF Department of Orthopedic Surgery. This session is titled Pandemics, Floods, and Earthquakes. It's good to be agile. We're joined again by, thank you, Tom Barber, who is the Associate Deputy Physician Chief of Perioperative Services at Memorial Sloan Kettering. Tom is also a former board member of the Academy and chair of its advocacy committee. And of course, Shauna Butler, who is my co-host and entrepreneur extraordinaire in the nursing world, and also host of her own podcast, See You Now, which I highly recommend. Just real quick, I also want to say that although this is the last official section, we do have 3 really excellent symposia coming on immediately after this from our partners at Johnson & Johnson, Zimmer Biomet, and modern medicine. And those sessions are going to be focusing on getting down into the more nitty-gritty aspects of delivering care through some of the digital platforms these companies have built. So with that little summary, let's get into pandemics, floods, and earthquakes.
Terrific.
Lions and tigers and bears. Oh my.
Right. So what's this talk about? At the end of the day, the question really comes up as to what can we learn from the past that we can apply to the future? What have we learned in this past few months that really gets us thinking again about how to handle very complex situations that arise that could be a pandemic, but it could be an earthquake here in San Francisco. It could be a flood in the Midwest. It could be a tornado in Tornado Alley. It could be raising floodwaters in Florida. So at the end of the day, they still require a rapid response, a change in the way we deliver care, a complete rethinking of our business structure. So those are the topics we wanted to address.
We're looking for all of the answers, Tom.
Yeah,
no problem.
Right?
I can do that easily.
Yeah, we thought this is a really tough topic.
Yeah,
That's what we need. Flexibility.
Yeah.
It's the watchword.
Well, it is interesting. I was actually 2 days ago was part of a conference that was done by the National Academy of Medicine, and they were looking at from the standpoint of, and they brought in public health officials and FEMA, and they were talking about, okay, so we are heading into a summer, and our summers, that's when we have our tropical storms coming in. We have our fires. And so all of those things are being planned for, only now they're being planned for from the standpoint of we're in the midst of a pandemic. And so they raise these really interesting questions. What happens? We've just been telling everybody shelter in place. And now we're saying evacuate. And when we tell people to evacuate, we tell them to go into shelters. How do you socially distance in a shelter? When we think about the way we've had our response teams, we frequently had response teams where we bring firefighters in from different regions. Well, do you really want to do that? So it was, I have to say, when I was listening to this, I was just getting a headache. And then I think the other pandemic, Tom, that I would love to have you speak about is the mental health pandemic. The loneliness, the isolation. So we've already had that challenge. I think we're more open and talking about it now, and we need to be able to continue delivering care. And we've got a group of care professionals who are struggling with that for any number of reasons. And we also have communities. So we are talking about the pandemic right now, as in coronavirus, but we've got pandemic layered upon pandemic. So I've just upped the ante for you. You're going to look so smart when you come up with all the answers for these.
I just want to let you know, though, I'm not a mental health practitioner, so perhaps I'm not the best one to comment on some of the loneliness aspect of things, but certainly some of the other things.
Yeah. So just to be clear, so one of the things that we want you to, because we talked a lot about the things that address the practitioner on a day-to-day basis, who to test, when to test, who to operate, where to operate, why to operate. We addressed that in the morning with you as well. And here it's about, okay, if you're thinking more system-wide, if you're thinking more about how to organize the assets that you have to be the most applicable, the most responsive to the problem, whether it be a serious psychiatric emergencies, which totally is at the end of the day a similar problem. How do you reallocate resource to meet a new need, or a pandemic, or an earthquake, or a fire? So
Or a
let's
riot.
start. Or right. Now we go. So in other words, lots of
Yeah, well, I
lots
mean,
of
I was just
things.
say protests. I mean, so from the standpoint,
Yeah.
I think what's interesting has been we've actually had a pause and we've had global solidarity. And we're seeing as we are reentering and coming out of our safe shelters, we're probably going to see some of the same things that we were having before.
Yeah.
One other thing I would throw into your list is strikes, because frankly, a lot of the response that we have to do from strikes actually helped me a lot in transitioning over to New York, because I had so much experience in dealing with strikes and the flexibility there, that going to New York in COVID were similar types of needs as far as the initial ramp down. So it's just something to think about. There's some parallels there. They're not exactly the same.
Fascinating. So this brings back to the question: how do you learn from varied experiences to optimize for the future? So let's ask you. Let's go with some questions along those lines. Tell me about your experience and what do you think of the need to have specific committees that are designed to help take on these challenges?
Yeah, I mean, I think that the most important thing you can have is a multidisciplinary committee that is well functioning, because you need to be able to communicate and understand all the ramifications of the decisions you make. It really has to involve nursing and physicians and patients as well, if you can. And I think that the critical nature of that committee, I can't underestimate or understate, because that committee has to respond quickly. They have to be able to make decisions, and they have to be able to move on a dime. And the second piece of that, though, is they need the data to make those decisions and establish the trigger points as to when they're going to do something. So it's great to say, hey, I'm going to stop doing surgery. Well, when? What is the trigger point at which you stop doing it? And when do you stop doing major surgeries versus when do you stop doing minor surgeries? What are those points? And how do you make that decision? And it has to be done in a multidisciplinary fashion. And it has to be done on a day-to-day basis. You can't meet once every 2 weeks. And what's really interesting is I've seen some real variability in terms of how Hicks structures work in hospitals.
What's the Hicks structure?
The Hicks structure is the incident command structure that's existing, the hospital incident command structure that exists in every hospital, UCSF, at Kaiser, and other places, as well as here. But some places, the Hicks structure is really involved in decision making. In some, it's more sort of a, let's all get together and sing Kumbaya and talk to each other about what's coming up without real decision-making authority. And there's a big difference there. And so I think, anyway, those are my thoughts initially.
I want to I've got a couple of follow-up questions on that.
Yeah.
You said we need to follow the data.
Yep.
I'm thinking we need to follow the science. I mean, the data is just collecting because we're looking at what science tells us, and that data is informing how we're doing that. And you had mentioned multiple disciplines. Those sound like they are inside of the hospital, because of so much of what we're dealing with is outside of. Who are those other people and other team members and resources and assets in the community need to be in that planning, so that we've got earlier surveillance and then also a better coordinated response?
There has to be a good connection, but they're not all sitting on the same committee, I would say. Okay, right. Because you have a real operational committee that has to make the operational details work, because they've got to decide how much you ramp down, what do you do, when do you reopen, real decision-making authority. And then you have to have a separate team that develops the scenarios. What are we looking at? How is this going to, at a high level, how many beds do you need to plan for in this pandemic? Is it going to be an extra 100? Is it going to be an extra 50, an extra 300? That's a really important decision making that may not lie with the way I describe it as sort of our our central decision-making operational committee that is in the operating room, perioperative space. And then you've got sort of a system-wide or hospital-wide group that includes infectious disease, experts from the state, others who are all coming in and informing the decisions and telling you sort of what's coming. They're telling you the size of the tidal wave, and you're at the ground level managing how that tidal wave is changing your practice. And if you mix them too much together, it's hard to keep straight what you need to be doing. If that makes some sense, is you really have to have operations separate from the projections, if you will. But you need the data on a real-time basis to really guide your decision-making. Because if you don't have that, and we had dashboards, to your point, of New York City and New York State, COVID cases, COVID hospitalizations, COVID deaths, so we could follow that, look how that would compare to China, to Italy, to other places. And so that would give us some insight. But then at the same time, we needed to know how many cases we had in-house and how was it really impacting us, because we needed, as a cancer center, to maintain our volumes as long as possible and restart them as soon as possible. And so we didn't want to go down to zero as far as our cases. So if we weren't watching things constantly, we couldn't put that balance in play.
So Tom, to make it practical, how often should these committees meet and who should be on them?
Well, I can tell you at our
not during, sorry, to be clear, not during the epidemic, but in just so they can be nimble, effective, and can get up and go on a dime.
Yeah, I mean, I think your committee there are a couple different committees and things that you want to structure. One is in the perioperative arena, and that's mostly what orthopedics is concerned with and all of that. You need a multidisciplinary committee with nursing, anesthesia, the head of surgery, whoever's administratively in charge, both in nursing, and if you have different facilities, you need representatives of those different facilities to make sure that that's there. You need folks that have a connection to, but not necessarily present, the EVS people, the scrub people, all those, the people to whom they report. So we had a nursing leader to whom all the folks in EVS and the folks doing the scrubs and that kind of thing reported to, and that was important in many of our decision making. And facilities people as well, is making sure you have those facilities people, because there are times when you need to change from negative to positive pressure, or from positive to negative, in this COVID crisis. And if you don't have the facility people there, they won't even know what you're talking about. You can't do anything. And you need clinical expertise there, because you will be making triage decisions, and those triage decisions must be made by clinical physicians. And I think that's the most important thing. And so what I would say is putting together that multidisciplinary committee and knowing who works well together, because this is not a process of politics. This is a process of process and making sure that it works. You can't be overly inclusive, because you have to have a group. We had a group of 8. If you get too big, it becomes totally non-functional. So it's got to be functional, but at the same time, work well.
I have another really practical question on this.
Yeah.
And again, listening around with different institutions. So when you do have those teams in place and they are tasked with gathering the information, one of the things that I hear over and over again from the C-suite is how important visibility and communication is important to building credibility. And so it is more frequent, the communication, who's doing the communicating, where it is that they're communicating from, and also what they're communicating. And a lot of it is what we didn't know, what we're learning, what we do know. So
and empathy.
A huge amount. But a big piece that I keep hearing, it's great to have those committees, but if you don't, and this Sachin Jain and Health Evolution there had several CEOs that were speaking about this, and it was really interesting hearing them talk about they would get online and they would have virtual town halls on a daily basis, these daily briefings with their teams. And it was that leadership group that was making these decisions. So again, these are some of the things that I'm hearing. Can you speak to that?
Really, really critical. And I would say that there are multiple levels of communication, and you can't forget them all. Because leadership communication about the direction the organization is taking, what we're doing at the 20,000 foot level is really important, so that the staff, the physicians, everybody knows what to expect and what's going forward. But at the same time, there are a lot of more specific questions that aren't going to be answered at that high level administrative meeting. So example for us, 35% of our CRNAs were out because they caught COVID.
Yeah.
Okay. And so
35%?
35%. So, and some of them caught them iatrogenically within the hospital. So the question really is then, how do you communicate with that group who's very fearful now, really doesn't want to move forward and help us in any way because they're feeling at risk? You need specific communication to the CRNA group, and that's not going to be done by the CEO of the hospital. You need to be able to understand their concerns, understand why that's a problem, and address them directly. So you need people at the table who are in those direct oversight and management roles who can then communicate to each group. One of the dangers I've seen and one of the downfalls is that the incident commanders want to control the communication so tightly that they just want the CEO to communicate, or just whoever's leading the effort at incident command. And everything needs to be approved by the committee for communication. That is really impossible, okay? Because that's great for the 20,000 foot view. It is not good for the local view. You need people who can get out to the people on the ground level, because I can tell you the people cleaning the floors need to know about this, and they're not going to hear it from the CEO. They need to understand the ramifications. So you need those communicators in that meeting.
Okay.
So Tom, we've built the infrastructure. We've got the communication piece figured out. We've gone past the thing. We're sitting here. Let's just be hopeful for a V recovery. It's January. All's good. What are we doing to prepare for the next one? Let's talk a little bit about flexibility. You mentioned that concept early on. Talk about flexibility in staffing and also in space utilization.
Yes, absolutely. I think the flexibility that I'm thinking about for the future right now, number one is critical care space for me. That's the highest on my agenda right now, because we were overloaded in critical care and we couldn't respond fast enough to have enough critical care resources to make this work. We had a critical care census that got doubled in the COVID environment, and it's still double, even though we're down to almost zero COVID patients now because they've all recovered, but they are still sitting in our critical care units, and the census there is still starting to go down. But over the next 6 to 12 months, we need about 50% more critical care beds or capacity than we ever had before COVID. So how do we get that over a 6-month period and have ICU availability for those patients? That's a challenge. So I am looking to the future and saying, look, we need a bigger ICU. We probably need a step-down unit that can convert quickly to an ICU if needed, even if it's not fully constructed as an ICU. So we can't be running ICUs at 100% capacity, which many hospitals do for a long, long time, because it's too expensive to provide that care. There's got to be some flexibility there. So I think that having an ICU with a little bit of extra capacity, even if it's 10%, whatever it could be, and having that flexible step-down unit is going to be really critical. The other thing I think in terms of preparation, especially in a surgical arena, is having outpatient arenas where you can do surgery, where you can change those patients. I can tell you in our arena, one of the best things we had a 24-hour stay facility that was 3 blocks away. We converted that to doing 3 to 5 day stays, and they were overnight stay, and that made a big difference. And so the fact that we were able to maintain patients in those locations, because we had enough 24-hour stay capability to do that, made a big difference. And again, that's flexibility. Can you move patients to the right environment at the right time? So I think the flexibility in terms of the building is there. I think we talked about that, and that's OR capacity, it's beds. What can you flex over to new beds at a given time? Do you have a plan for that? Maybe it's taking over a clinic, maybe it's taking over some other area. But if you don't have that in the back of your head, you're not going to think about it. So that's the flexibility in space I'm thinking about, that you can't have everything so tightly planned that you have no flexibility. The second thing is flexibility in staffing. And I can tell you that we're undergoing a big process right now, looking at every employee who worked from home. And this is a little more challenging and is very difficult, I think, discussion, because people are very, very much define themselves as going to work, right? So as we start looking going forward, can we provide additional flexibility on the space side by having more people work from home in a normal situation? So post-COVID, are we going to have people come in 2 days a week and work from home 3 days a week? And how can we do that? And we're actually looking at every role in the hospital and research setting to say who could potentially work from home long-term and how is that going to work? And they need to be connected with us for sure as an institution. So does that mean coming in 2 days a week, 3 days a week? Not sure, but I think that kind of discussion and allowing people to be flexible. And the third piece, and so that the roles have to be flexible in terms of what you can do, coming in and out quickly if you need to be. The last thing I would say is you need the technical resources to allow you to do that. A lot of places, WebExes would go down, Zooms would go down. There wasn't enough technical capability to actually do what you had to do. And that's challenging. The last piece is having the data resources, dashboards that can be easily constructed on the fly to find you the data that you need. So those are all the flexibility that you need. If you can pull it together, it can bode well for the future. Does
Tom,
that make sense?
It does. And I had a question around when you're talking about flexibility. One of the things also is mobility and agility. So we're talking about, we're thinking, the conversation that we're having, what I'm hearing in my head is that we're talking about virus, an outbreak of COVID. What does it look like when you've got some type of a natural disaster and it's not a function of just telling people to go home and to be able to work from home, their home isn't there. What does it look like for us to be able to mobilize so that we are going to have ill and injured people? How do we mobilize the workforce and the response so that maybe it can respond? Either, we've got a group of people that leave and go to that location, or how do we serve them in a remote way?
Well, I think that the mobility and agility are what's really critical here. And you have to have the resources to allow that. So if we have a main facility in Manhattan and we're hit by a hurricane and, the water is going to shut down the power, how do we then transition those people to other facilities, perhaps the one that's 3 blocks away that's unaffected? How do we actually make those shifts in a very fast manner? That agility is really important, and most healthcare facilities are not good at that. It takes years to turn the Titanic or a large hospital system very often, right? So how do you provide that agility if you've thought about it in advance and you actually have a plan as to how work could change in the future, not dictate that it should change in that way, but how could it change? Then you have those options available to you when you sit down and you're facing this crisis. Because you should know, for instance, what percentage of your census is going to decrease every day that you shut down elective surgery, and how is that going to affect your plans? Those kinds of numbers are things that I think are important for you and your institution to know. And it's different in different facilities. So I can't just tell you, hey, it's going to be 10% a day. It depends on the facility. But you need to know your facility and know what are the levers that you can pull to ramp up and ramp down and to ramp over and be mobile somewhere else.
Yeah.
And if you haven't thought about that in advance, you spend a good 3 or 4 weeks just deciding what your possibilities are rather than deciding what to do. And you can't afford those 3 weeks of let's explore what the possibilities are. You want to do that in advance.
Scenario planning, a lot of it.
Yep, exactly.
Tom, actually, I think I was going to go to structural things, which I really like to talk about, but Sean and I have had this conversation as well, that as we started looking into what happened in the past 2 months, it was so interesting to see how those organizations that had planned for digital, they're already exploring it, could just ramp up. It was there, it was available, boom, off you go. You know, they take a little while to get everybody lined up, but it wasn't a matter of finding the right vendor. And I was talking to you, actually, Tom. You talked a little bit about your telehealth experience, as you now have 3 telehealth platforms that you guys have to figure out, because you deployed them quickly, and now you have 3 of them. Something along those lines. You want to talk about that?
Yeah, no, absolutely. It was challenging because we had an approved, sort of HIPAA approved, installation that we were going to use, but that couldn't scale as fast as some of the other things. So we ended up using a lot of Zoom. We used a lot of FaceTime. We used things that in the traditional healthcare environment, because of HIPAA protections, would not be allowed. So that was very challenging, because I think a lot of the traditional ones were not as scalable as you would like. And so you have to make compromises as you do that. And it's unfortunate, but we did. And now that everybody's familiar with it, we can shift to any resource we need to or want to. I think the other thing that I found was incredibly important in this crisis was the ability of IT to respond quickly to changes that needed to happen tomorrow. How do you come up with an app that will actually ask questions of your employees, so you can screen your employees before they go to work, and they can walk in and see the green on your screen to indicate that you have been approved to go to work? You have to have an agile IT structure that can redeploy quickly to do those kinds of things. And IT's not used to doing that in that way in hospitals.
So I had 2 members from the ATA association earlier. So, and Mon Johnson and then Joe Kvader, and they commented on this very, very well. And one of the things that they said, first of all, to your point, was all the different ways that the different technologies. And the first thing that they said, just a phone call made a huge difference. So, and it was available to so many people. So rather than trying to have a computer and what's your internet access, they got so much done by phone, and particularly those folks who were at greatest risk. So there was that they were thinking about. And the other part, when you talk about your IT teams, part of this is a culture that we've created, and that culture is being resistant or fearful and protective from the standpoint of we can't do that, we can't do that, we can't do that, as opposed to in the moment when it's not a function of you're not allowed to, you have to. It was still very hard, the mental shift to be able to make that, because you're just so ingrained, like that would be not right, that would be dangerous, that would be, it was very fear-based because of the intense penalties that are put in place for any of these violations. So I think that that's, something that we need to think about, is how do we develop those mindsets?
I think the other thing you're dealing with, Shauna, in hospitals is the silo mentalities. And that is a really difficult thing to deal with, because most of the IT people and the data people are used to spending months getting approvals from every which committee before they go live with anything. Okay, and suddenly you're in a situation where you have to do something this week. You can't possibly check with every committee and find out what the best way is. You're going to put something in that works. And, that is freeing in a way, but it also is scary for a lot of people in the hospital. And I can tell you that there were a lot of times when people were like, well, that's just not the way we do things. And it's like,
that was exactly what they said.
We have to do them this way.
It was the attitude that was the issue.
Right. So how do you solve that? I mean, we can describe the problem, but I want to get to solutions. So you know that's an issue. How do you solve it? Is that a directive? Is that a communication? Is it kumbaya, bring everybody in the room? What worked for you, Tom?
I think there are 2 things that worked. One is the senior leaders were very direct in saying something has to be done quickly and has to be done here. But interestingly, there's one interesting anecdote, I think, to me is one of the first things I did when I established the emergency committee that we were looking at peri-op services and what we're going to do is I also brought in a data team, and we had 3 people who were going to develop a dashboard. We've got a great dashboard within 3 days of everything we needed. And the first thing I was told is, you can't show this to anybody. because it's too good and everybody else is going to want it, and you're going to threaten all of the things that have been done in the past. And so for 2 weeks, we didn't show anybody because, it was thought that we were getting into too many other people's areas and people would be upset. And then finally, people looked at it and they said, oh, this is really good. We need this. And they brought it to the higher level, but it was, it was playing the balance. Is getting what you need at first without showing it to everybody. So it was developing sort of in a vacuum, if you will, which is not the ideal. It's skunks works. You develop it, and then you go live with it, and you're a little bit careful about the communication. Then eventually everybody's going to want it. And so you make sure that you're willing and able to share it immediately as soon as that's more open. But in the initial couple of weeks of the pandemic, and I think in any crisis, people are still holding on to their previous values, no matter how bad the crisis is. And so you need to loosen that up a little bit. That's all.
And speaking of loosening it up, one of the things that I've heard from a lot of the frontline responders, that getting over that resistance has been by moving the decision-making closer to the problem and empowering people there, that actually, and what I've heard from many people is that they've never had such a strong sense of camaraderie and clarity of purpose when they have been empowered to say, if you see the problem, work as a team, figure it out. And so rather than trying to have this command and control structure on things that are really oftentimes operational, we need to solve that particular problem. That's what I have heard, is that to get over this, rather than trying to do a central, it's like push the decision-making as close to the problem and the solution as you can. So you want to care to respond to that and what you'd recommend?
Yeah, no, I agree. You need to push it down, but you also have to have the senior leaders to be able to respond. And I don't mean to stop, but they have to know what's reasonable. A couple of decisions that were pushed down that I think were really critical, I think, in our COVID response. One was the nurses on the floor and the personnel on the floor needed scrubs. There were no scrub machines on the floor. So one of the nurses in the OR said, well, let's just give them one of ours. We have 2. And we said, okay. Within an hour, we had the scrub machine moved to a different floor because IT was willing to support it. And they were able to put scrubs on the COVID floor so that everybody could get their own scrubs and feel safe and not have to go home and wash their COVID stuff. I know but that's sort of where you go to the ground level. Another example of that was, the urgent care center saying, we can't diagnose our COVID patients fast enough. And we were like, well, what do you need? And they go, we need a CT scan. And we said, okay. Well, by the end of the day, we had them a CT scan. We sent them the Aero CT from the operating room. Because the people in the operating room were willing to ship it down without checking with anybody. And believe me, I heard from the spine surgeons the next day that why are you shipping? Where did it go? But it was necessary and it had to be done. You know what I mean? So those kinds of things can work because it was their brand new Aero CT that they just got in a week before. So they were not happy with the fact that we set it down below, but it worked. And so, yes, that it has to go down to the lower level and you have to make rapid decisions. You can't let it trickle up through the decision-making tree.
Okay, in the last minute of the session, I just want to talk a little bit because you mentioned this idea of flexibility. If you had to build a new hospital, what considerations would you have in terms of how you might restructure it?
I think there's 2 things. I would put ambulatory surgery and 24-hour stays separate from the hospital to provide that flexibility if you can at all. Okay, because you need that flexible space. I would make sure that you have space that's convertible to an ICU if you need it, and I would plan for a more robust ICU in terms of number of beds than you would normally plan for. I think that's a really important thing, and you need more monitored spaces that can be converted to an ICU. One example of that is having a robust PACU. If you have a robust PACU, you might be able to convert that to ICU very quickly. So I think that that's one possibility. So I'd build probably a big PACU that could convert to an ICU. I'd build step-down units, and I'd build a bigger ICU than I thought I needed.
But you also talked about maybe not building as much administrative space because...
Yes. I think a lot of work could be done at home, and I think that you ought to build it with that in mind. So you have less administrative space, and people should be doing it from remote locations.
Well, I think we covered a lot of things we can learn from the past and apply to the future. And whether it's in, what was it again? We had pandemics and earthquakes and everything else lined up. Sean, do you want to...
Fires and strikes, we've seen those.
Yeah, well, I will, from the standpoint of when you're talking about like I said, some of the things that are on my mind that I hope that we're thinking about and planning for, because I think when we plan for them, we can prevent them. That's, from the standpoint of we're a hero loving culture. We love all of those stories around it. Nobody gets excited about the catastrophe that never happened, unless of course you're in public health, which we love preventing them. But one of those things I think as we start thinking about what could possibly happen, what could possibly go wrong, what I'm worried about right now is the drop in childhood immunizations. And we see how rapidly those goes. These are things that are preventable. So when we start taking a look at what could possibly go wrong, A, we can prevent some things. B, when they do happen, because they will, we will be better prepared. And I think it's a way of actually helping us to build in resilience. And that resilience is what's going to keep us safe as responders so that we can do the work of caring. And that's, I think, my greatest concern is if we don't take care of the people who keep things running and keep us healthy and recovering or dying in peace, then we are really in a bad space. And I know that we're better people and we're good, smart. We want to do the right thing. So I thank you so much for giving the insights around what we need to be thinking about, how we need to be preparing, and doing it with empathy, kindness, caring, laughter, a lot of dancing and songs. I think my favorite scenes right now in New York are all the extubation dances. When people are extubated throughout the hospital, different hospitals have songs that they play over the loudspeaker, and it's building the morale and the camaraderie. We cannot do this independently. We're all in it together, and it's going to take us all to solve it.
One of the best things every night at 7:00 to hear the pots and pans bang in New York was always a reminder to all of us what we're doing, why we're doing it, and it made a difference.
It was as much for the people who were clapping as the people who were being cheered along. So,
yep, it's good.
Tom, I'll bid you bye. I'm going to take a second with Shauna to wrap things up. And but thank you again for participating, and look forward to hearing more from you and the great work you're doing in New York.
Wash your hands. Be well. We love New York.
Yes. Thank you. Bye.
All right, Shauna, we're coming to the end of our session. In about a minute, we're going to go into three actually amazing symposia.
That's right. We're going to go into a deeper dive, and there's a lot of, we're talking at the high concept level, and we're talking about a broad range of topics that give us the information that we need, so that when we go into our local, our health systems, with our own cities, with our own neighborhoods, we need to have that information, those tools, and those resources. But we want to spend a little bit of time going really deep on a very specific issue. So that's why we put the symposia together, to allow people that time to one specific topic and go at it into detail it to death.
Awesome. And we got two in parallel and then one to follow. So up next is Zimmer Biomet with maximizing remote care management. And then the J&J DePuy Synthes, impact on outpatient total hip arthroplasty. So all you have to do is select from your section. The schedule is the top, just above our pictures here. There's a little bar that says schedule. You pull that down and then select one or the other, and they'll be both going live in about 1 minute or 2 minutes by the time we get done.
So once again, it's been great. It's always good to be with you virtually. I have to say, I'm I miss seeing you in real life.
It's always such fun to have you on stage.
Yeah, I was going to say, you know, the virtual hug. It's I'm missing the real ones.
Let's get this recovery on the road until
That's
this Friday.
right.
We give it a push, and so let's see what we can do. On to our symposium.
Great.
Thank you.